findings, they take time to develop. They take 12 to 24 hours. That's why pulmonary contusions, immediately if you do the X-ray, it may be normal, but it will develop. It's a potentially lethal. It's not immediately killing. Immediately killing will be massive pneumothorax, tension pneumothorax, some which is immediate, but they will develop over time. So then, how to diagnose? First, you have to suspect. Strong clinical suspicion based on the history of mechanism of injury. So that's the most important. Never forget how the injury happened. And from the mode of injury, you have a strong suspicion. And you have to sometimes you have to go for a CT scan to confirm it. Okay. Otherwise, you won't be able to find it. Huh? Okay. So treatment ki hobe? Obviously, you have to supplement. First is always oxygen supplementation. Huh? And you have to monitor the oxygen saturation. Okay. Obviously, patient will be in pain. Analgesia is always important because if you can't make the patient pain free, what will happen? If someone has some lesion in the chest and having pain, what will happen? আমাদের যখন পায়ে লাগে আমরা কি করি? কিভাবে হাঁটি? খুঁড়িয়ে হাঁটি না? হ্যাঁ? কেন? পেনের জন্য। So we try to keep rest to that area. So similarly the chest, আমাদের যে নরমাল যে ইন্সপিরেশন মুভমেন্ট চেস্ট এরকম এক্সপ্যান্ড করছে ইয়ে হচ্ছে। So if you don't give analgesia, we don't take deep breath, we will take shallow breath. Shallow breath means less tidal volume. So less tidal volume means again less gas exchange. Already the lung is compromised. On the top of that, even the tidal volume is also not good. So that's why in any chest injuries, supplemental oxygen, analgesia is very important. And you have to promote always chest physiotherapy. That means aggressive pulmonary toileting. Because unless you do promote chest physiotherapy, you encourage the patient to cough. All secretions will be pent up. So you have to clear the roads also, na? ধরো রাস্তায় যদি একটা ডেব্রি পড়ে থাকে তাহলে কি করতে হবে প্রথমে আর কি ডেব্রিটাকে তো সরাতে হবে you clean the road, na? So similar. So once the chest is bad, you have to go for an aggressive pulmonary toileting also. That's only possible when you give some oxygen and you administer good analgesia to make the patient pain free. Otherwise you won't breathe. তুমি যতই বলো না কেন করবে না। Have you ever seen ওপিডিতে আমি অনেক সময় বলি পেশেন্টকে একটা স্পাইরোমিটার করতে বলি, হ্যাভ ইউ এভার সিন? তিনটে বলে স্পাইরোমিটার করতে বলি। বড় যে কোনো বড় ওটিতে দেখেছো স্পাইরোমিটার তিনটে বলে স্পাইরোমিটার? দেখেছো তো স্পাইরোমিটার? সো যে কোনো বড় ওটিতে কি হয়, যে কোনো বড় অ্যাবডোমিনাল সার্জারি বা হলে আমরা কি বলি যে স্পাইরো করবেন আগে থেকে। হোয়াই? বিকজ আফটার দ্য অপারেশন ইটস a natural tendency. Patient will have pain, no? Pain on inspiration. So they will have shallow breath. So there will be alveolar collapse. So to prevent that, you have to do it. And you have to optimize beforehand. Trauma ক্ষেত্রে তো তুমি আর জানো না কবে ট্রমা হবে, but elective surgery we do it 2 weeks prior to the surgery so that the lungs is optimized. So that's the aggressive pulmonary toilet. So now the management based on 3 factors: overall stability, because many of the times patient will have other associated injuries. Okay, how adequate is the oxygenation and how is the pulmonary mechanics. Okay, some patients, suppose the patient নিজে থেকেই সব কিছু করতে পারছে, হ্যাঁ, তাহলে তো শুধু অক্সিজেন সাপ্লিমেন্ট আর অ্যানালজেসিয়া আর ইয়ে দিয়েই হয়ে যাবে। সাপোজ পেশেন্ট নিজে থেকে নিতে পারছে না, হচ্ছে না, তাহলে কি দিতে হবে? পেশেন্টকে কিসে চাপাতে হবে? ভেন্টিলেশনে চাপাতে হবে। সো পেশেন্ট যেটা নিজে করতে পারছে না, ভেন্টিলেটর সেটা করে দেবে আর কি। তাহলে কাদের আমরা ভেন্টিলেটর চাপাবো না? কি কি প্যারামিটার থাকলে ঠিক আছে একে ভেন্টিলেটর না দিলেও চলবে? তাহলে কি কি প্যারামিটার আমরা দেখি তাহলে? কি কি বলো? হ্যাঁ, যে রেসপিরেটরি রেট নর্মাল, বিকজ যদি রেসপিরেটরি রেট মানে গ্যাস এক্সচেঞ্জ যদি ঠিকঠাক না হয় তাহলে কি আর রেসপিরেটরি রেট বাড়তে থাকবে, তাই না? রেসপিরেটরি অনেক বেশি হয়ে যাবে, 24-এর বেশি। নর্মালি কত? 18 থেকে 20-22 এরকম হয়। সো রেসপিরেটরি 24-এর নিচে থাকতে হবে, নাম্বার 1। PaO2 60-এর বেশি রাখতে হবে। এবার সাপ্লিমেন্টাল অক্সিজেন দিয়ে ধরো FiO2, নর্মাল FiO2 কত? এয়ারের FiO2 কত? হ্যাঁ, এয়ারের FiO2 কত? হোয়াট ইজ FiO2? ফিজিওলজি তো FiO2 পড়িয়েছে তো, হ্যাঁ? হোয়াট ইজ FiO2? ফিজিওলজি তো পড়ায়নি FiO2। কোয়েশ্চেন তেরো মাস সব নেক্সট ডে একটা ট্রমা দিয়ে দেবে, এরকম দিয়ে দেবে on FiO2 this that. What is FiO2? This is fraction of oxygen in the inspired air. So how is the FiO2 in inspired air? আমরা যে নিঃশ্বাস নিচ্ছি কত অ্যাটমসফিয়ারে কত অক্সিজেন থাকে? হ্যাঁ 21%. That means FiO2 will be 0.21. So 0.21, ঠিক আছে? এবার দেখবি যখন অক্সিজেন দেওয়া হয়, অক্সিজেনের ইয়েতে মানে যেখানে ভালভ থাকে, যেখানে ওখানে লেখা থাকে কত কত ফ্লোতে যাচ্ছে, FiO2 কত হবে সেরকম হয়। সো 50% FiO2 তে, তার মানে কি অ্যাটমসফিয়ারিক অক্সিজেন যা থাকে তার থেকে আমরা FiO2 বাড়িয়ে দিচ্ছি আর কি। বিকজ পেশেন্টটা তো অক্সিজেন ঠিক মতো হচ্ছে না, দ্যাটস ওয়াই ইউ আর গিভিং মোর অক্সিজেন। ঠিক আছে, একটা জিনিস বলতো 100% অক্সিজেন ইজ গুড আর ব্যাড? Is it toxic? No. Sometimes for very short period we give 100%, but quickly we come down because that's toxic. So at least on 50% FiO2 তে PO2 should be more than 60. ABG করলে more than 60. এটা ABG করলে পাওয়া যাবে। ঠিক আছে, respirate less than 24. Tidal volume is always body weight এর সঙ্গে related. So tidal volume should be more than 5 ml per kg. মানে 50 যদি বডি ওয়েট হয় অ্যাটলিস্ট 250 বেশি টাইডাল ভলিউম জেনারেট করতে হবে। হ্যাঁ, আর ভাইটাল ক্যাপাসিটি হচ্ছে মোর দ্যান 10 ml per kg। ওকে, এই সব ফিজিওলজিতে পড়ানো হয়েছে। সো এই যদি থাকে তাহলে পেশেন্টকে আমার ভেন্টিলেটর না দিলেও চলবে। তাহলে আমরা কাকে ভেন্টিলেটর দেবো? ইনটুবেশন এন্ড ভেন্টিলেশন। ভেন্টিলেটর চাপাতে গেলে তো আমাকে তাহলে ইনটুবেট করতে হবে না, উই হ্যাভ টু গিভ এ টিউব so that from machine directly আমি যেভাবে সেট করে দেবো ডাইরেক্টলি the air will come. হ্যাঁ, তাহলে যদি PO2 less than 60, FiO2 50%, ঠিক আছে? এবার PO2 by FiO2 নর্মাল রেশিও কত? 500. ইনটুবেশন ইন্ডিকেটেড যদি রেশিও বিলো 300 হয়, PaO2 by FiO2। এগুলো সব এমসিকিউতে আসে কিন্তু। PaO2 by FiO2, PO2 is partial pressure of oxygen. We'll get it in the arterial blood gas. If I do the ABG, only then we will be able to know the PO2. Okay, so PO2 by FiO2 যদি 300 নিচে হয়, we should go for intubation. Okay, so ventilator FiO2 should not exceed 50% to maintain a PO2 of more than 60. যদি এতে মেনটেন না করা যায়, মানে FiO2 50% দিয়েও PO2 60% হচ্ছে না, দেন আমাদের তাহলে অ্যাড করতে হবে PEEP or CPAP. What is PEEP? ফিজিওলজি পড়ায়নি? PEEP নিশ্চয়ই পড়েছে। পজিটিভ এন্ড এক্সপিরেটরি প্রেশার। একটা জিনিস ভাবো, আমরা যখন এক্সপিরেশন হচ্ছে তখন কি হয়? তখন টার্মিনাল অ্যালভিওলি কিরকম হয়? কোলাস হয়ে যায় না? নিঃশ্বাস নিলাম, হাওয়া ঢুকলো, হ্যাঁ, ট্রাকিয়া দিয়ে গিয়ে ব্রঙ্কি হয়ে একদম অ্যালভিওলি অবধি পৌঁছে গেল। আবার যখন আমরা হাওয়া ছেড়ে দিচ্ছি, এক্সপিরেশন হচ্ছে যখন, সব হাওয়া বেরিয়ে গেল, সো অ্যালভিওলিগুলো তখন চুপসে যায়, তাই না? বাট এখানে যেহেতু অক্সিজেনেশন ঠিকমতো হচ্ছে না, আমরা চেষ্টা করি একটা পজিটিভ ইভেন এট দ্য এন্ড অফ এক্সপিরেশন অলসো টু মেনটেন এ পজিটিভ প্রেশার দেয়ার। দ্যাটস আ PEEP, পজিটিভ এন্ড এক্সপিরেটরি প্রেশার। Even at the end of expiration, there will be some positive pressure on the terminal alveoli. That's called positive end expiratory pressure. And what is CPAP? Continuous positive airway pressure. So airway pressure continuously positive রাখা, যাতে even end of expiration there will be some gas exchange, পুরোটা collapse না করে যায়। So that's the PEEP or CPAP. ঠিক আছে? কেউ নাম শুনুনি? সিপ্যাপ মেশিন অনেকে বাড়িতে রাখে, সিপ্যাপ মেশিন, বাইপ্যাপ মেশিন, দেখুনি? আচ্ছা, ওকে। নাও নেক্সট ইজ অ্যাওরটিক ডিসরাপশন। কিভাবে হয়? এগেন ইউজুয়ালি র্যাপিড ডিসেলারেশন ইনজুরি থেকে হয়। ধরো কেউ খুব স্পিডে যাচ্ছে, ভেরি স্পিডে যাচ্ছে, অ্যাক্সিডেন্ট হলো, তাহলে কি হয়? উইদিন সেকেন্ডস, 2 to 3 seconds, say from 100, যত হাই স্পিড অ্যাক্সিডেন্ট হয়, হ্যাঁ, এই যে কদিন আগে সাইরাস মিস্ত্রি মারা গেছে, শুনেছিলে? টাটার ম্যানেজিং ডিরেক্টর ছিল সাইরাস মিস্ত্রি। high-end car crash, BMW na kishe. So they were moving at a speed of say 200 kilometers per hour, Mumbai Pune highway. Met a crash and then died immediately. Cyrus Messi died immediately. So what are the mechanisms of injury? So এই যে rapid deceleration হয়, এটা 200 কিলোমিটারে যাচ্ছিল, within 3 seconds full stop. I mean stand still. কি হয়? এই rapid deceleration না, there is a shearing force on aorta and other great vessels হয়। এবার ডিসেন্ডিং অ্যাওর্টাটা ভাবো, ডিসেন্ডিং এরিয়াটা তো ভার্টিব্রার পাশ দিয়ে আসছে, ডিসেন্ডিং এরিয়া হচ্ছে ফিক্স, আর হার্ট থেকে অ্যাসেন্ডিং অ্যাওর্টা এরকম বেরোচ্ছে, আর্চ অফ অ্যাওর্টা হয়ে ডিসেন্ডিং অ্যাওর্টা হচ্ছে। এবার এই যে এখান থেকে যে এরকম বেরোলো অ্যাওর্টিক আর্চ অফ অ্যাওর্টা, ওখান থেকে তো 3টে ব্রাঞ্চ যায়। কি কি ব্রাঞ্চ যায় আর্চ অফ অ্যাওর্টার? কি ব্রাঞ্চ আর্চ অফ অ্যাওর্টার? কি ব্রাঞ্চ? এই যে 3টে যাচ্ছে এরকম করে বাঁ দিকে আসছে, সবচেয়ে ডিস্টাল কোনটা হবে? ডিস্টাল সাবক্লেভিয়ান, হ্যাঁ তাই না? সাবক্লেভিয়ান, বাঁদিকে সাবক্লেভিয়ান, এদিকে তো রাইটে তো ইয়ে হয়ে বেরোচ্ছে, ব্রেকিওসেফালিক হয়ে বেরোচ্ছে, সাবক্লেভিয়ান। এবং ওখানে লিগামেন্টাম আর্টেরিয়াসম যে লাগবে, ঠিক যেখান থেকে এই যে লাস্ট বেরিয়ে গেল, তারপর যে জায়গাটা হার্টের মুভমেন্টে না, ওই জায়গাটা একটু ফ্রি থাকে, দে আর নট ফিক্স লাইক ডিসেন্ডিং অ্যাওর্টা। সো কোন জায়গাটা ছিঁড়ে যায়? সবসময় ছেড়ে হচ্ছে যেখানটা ফিক্স আর যেখানটা মোবাইল, ওই জাংশনে ছিঁড়ে যায়। সো র্যাপিড ডিসেলারেশন যদি হয় তাহলে ইউজুয়ালি ওই রকম জায়গায় এটা টিয়ার হয়। হ্যাঁ, টিয়ারটা পার্শিয়াল হতে পারে, কমপ্লিট হতে পারে। কমপ্লিট টিয়ার যদি হয়, is usually a death at the scene. Okay, you can't revive. If the aorta ruptures, you can't revive. Partial হলে still is a possible, যদি তুমি কুইকলি ইন্টারভেন করো। যদি ইন্টারভেন না করো তাহলে they will die say within 6 hours. Still you have some time. So most common site of tear or rupture the aorta হচ্ছে descending portion distal to the left supplemental artery at the ligamentum arteriosum. কারণ ওইখানে হার্ট অ্যান্ড এটা একটু মুভমেন্ট হতে পারে। ডিসেন্ডিং অ্যাওর্টা ইজ ফিক্স, সো ফিক্স আর মোবাইল জায়গার যে জাংশন, সেইখান থেকে ম্যাক্সিমাম টিয়ারটা হয়। ওকে, সো আদার সাইডস হচ্ছে যেখানে অ্যাওর্টা লিভস দ্য পেরিকার্ডাল স্যাক আর দ্য এন্ট্রি অফ ডায়াফ্রাম, যেখানে একটু মোবিলিটি হতে পারে, সেই সব জায়গাগুলোতে হতে পারে, যেখানে ফিক্স সেখানে ইউজুয়ালি হয় না। সো ক্লিনিক্যাল প্রেজেন্টেশন ভেরি স্পেসিফিক, যদিও সাম পেশেন্টস মে রিমেইন সিমটম ফ্রি। No external signs of chest trauma up to 50% because it's a deceleration injury. May not be any external marks. That's why you always remember, mechanism of injury is more important. Symptoms and sign can be very subtle. There may not be any obvious injury. Nothing external. Okay, so that's very important. Always, any trauma, the mechanism of injury is more important. You have to identify যে ওখান থেকে আমাকে ভাবতে হবে যে মানে হ্যাভ টু ইনভেস্টিগেট দিস পেশেন্ট। বাইরে কোনো ইঞ্জুরি নেই তার মানে পেশেন্টের ইঞ্জুরি নেই, ইটস নট লাইক দ্যাট। পেশেন্ট with a aortic injury, there may not be any external signs of chest trauma in half of the patients. Okay, so what is the single most important factor in establishing the diagnosis? High index of suspicion based on mechanism of injury. Okay, there may be sternal or posterior interscapular pain, may have dyspnea, patient may have hoarseness. Usually যেটা হয় hematoma causing pressure on aortic arch, and যদি aortic injury হয় অনেক সময় lower extremity paralysis ও হতে পারে। তাহলে possible sign কি হবে? pulse deficit হতে পারে, ঠিক আছে, lower extremity তে হতে পারে, left arm এ হতে পারে। Hypotension unexplained by other injuries, দেখতে লিভার, মানে আমরা অনেক সময় ফাস্ট করি না, I told about ফাস্ট আর ফাস্ট, abdominal injury নেই, stomach injury নেই, হ্যাঁ, pericardial tamponade নেই, but still এটা হতে পারে। Hypotension, unexplained hypotension, and upper extremity hypertension compared with the lower extremity. Okay, and if you get a murmur, auscultation of a precardial or interscapular systolic murmur, that's specific. If you do a chest X-ray, there will be widened mediastinum because of the hemorrhage, na? So mediastinum will be widened more than 8 centimeter যদি হয় and aortic knob obscured, you always think or always suspect there may be aortic injury. Okay, if the chest X-ray is questionable, always we go for CT thorax, but even in CT thorax overall accuracy is 53%. So gold standard for any vessel injury is always an angiography. So for aorta, it will be an aortography. Okay. So usually they need surgical intervention, and until the patient is ready for surgery, major focus will be to keep BP slightly lower. If you diagnose a case of aortic injury, this is the only scenario where we try to keep a BP on a lower side. Normally we try to keep BP at least 90 or higher. This is the only scenario where we try to keep a lower BP if I confidently diagnose aortic injury, or with the investigations we diagnose an aortic injury. Until as OT everything is ready, we try to keep the BP, because if we increase the BP, it may, even a partial rupture may aggravate. So this is the only scenario where we keep a slightly lower BP. ওই যে অ্যাওর্টিক না চেস্ট এক্সরে মনে আছে, একটা অ্যাওর্টিক নব থাকে এরকম পড়েছিল নর্মাল চেস্ট এক্সরেতে, দ্যাট উইল বি অবস্কিউরড, মানে কি ওখানে কোনো হেমাটোমা হয়েছে নিশ্চয়ই, তাই না? সো দ্যাটস ওয়াই ইউ ক্যান গেট অবস্কিউরড অ্যাওর্টিক নব। Always protect the airways, intubate if required, give oxygens, fluids, pain control definitely, yeah, because it will help, because if the pain is not controlled adequately, because of the pain BP may rise, okay, na? So prognosis depends on early recognitions and prompt treatment, okay? But post injury there may be some complications, hypertension hote pare, paraplegia hote pare, because of the aortic injury perfusions to other organs are impaired, no? So renal failure jete pare, bowel ischemia hote pare, এইগুলো হতে পারে আর কি, হ্যাঁ, because the perfusion অনেক সময় যদি 90 নিচে হয় তো other organ may take a hit, secondary hit আর কি, because of the hypotension. Next is myocardial contusion. Myocardial contusion মানে হচ্ছে again bruise to the myocardial tissues. So myocardium will be damaged. Okay, there will be extravascular erythrocytes into the muscle wall. Some area will be necrotic. Okay. Oh. Some area will be necrotic. So that means if some area of the muscle, myocardium মানে কি heart muscle, if some of the muscle is necrotic or not functioning properly, what will happen? What will happen to the contractility of the heart? What will happen? Any dead muscle means that muscle cannot contract. So the main function of heart is pumping. So depending on how much muscle is dead, that portion of the heart won't be effectively contracting, right? So blunt testimony up to 75% of patients may have. There is কোনো এরকম হয় না যে এত পার্সেন্টে হতে হবে, it's a range. So it may be 3%, it may be 70%. So different cities will have different percentage, but it can be as high as 3 out of 4 myocardial contusion. Okay. So high-speed deceleration collisions, the most common cause. Suspect in all patients involved in MVCs 20 mile per hour. 20 mile per hour means 36 kilometer per hour, na? 1 mile is 1.6 kilometer. So 35-36 kilometer এর উপরে যদি আমরা লাগে, always suspect. Okay. And 20% of patients with steering wheel impact sustain cardiac contusions, and 16% will be fatal. So হার্টে মাসলে যদি প্রবলেম হয়, নর্মালি ওরা প্রেজেন্ট করে কিভাবে? অ্যারিথমিয়াস দিয়ে, না? সাইনাস নাও পেতে পারো। সো দেয়ার মে বি ডিসরিথমিয়াস, ওকে, অ্যান্ড ট্রমাটিক মায়োকার্ডিয়াল ইনফারকশনের মতো। সো হার্ট ফেলিওরও হতে পারে ওই জায়গাটা যদি পাম্প না করে। সো দেয়ার মে বি হার্ট ফেলিওর, দেয়ার মে বি পাম্প ফেলিওর, হ্যাঁ, সো দেয়ার মে বি হাইপোটেনশন। জাস্ট এগুলো মানে ভেবে ভেবে বার করতে পারবে যে কি কি সিমটমস হতে পারে পেশেন্টের। অ্যান্ড অ্যারিথমিয়াস, হার্টে যদি কোনো প্রবলেম হয়, দেয়ার মে বি arrhythmias. So there may be congestive heart failure, there may be cardiac rupture. You can just think and make symptoms. So clinical presentation usually dysrhythmias. Any trauma patients having arrhythmias, always think patient may have cardiac contusion. Most common dysrhythmia, sinus tachycardia. এছাড়া সব রকমই হতে পারে। So dysrhythmias in a chest trauma patient should always indicate cardiac contrition until proven otherwise. Okay. So how to diagnose? You do an ECG. Okay. If the admission ECG is abnormal, monitor continuously for the next 24 to 48 hours because most arrhythmias they occur within that. মাসল ড্যামেজ হলে একটা হচ্ছে ইসিজি হলো, ঠিক আছে, আর কি কি দেখা যেতে পারে? মাসল ড্যামেজ হলে আর কি কি হতে পারে? হ্যাঁ, সো সিকে এন্ড সিকেএমবি, ঠিক আছে। সো বাট দে আর নন স্পেসিফিক টু মাসল ইনজুরি বিকজ যদি ট্রমা পেশেন্ট তো স্কেলেটাল মাসল ইনজুরিও হতে পারে, তাতেও মানে বাড়তে পারে, ঠিক আছে। অ্যান্ড এলিভেটেড ট্রোপোনিন লেভেলস হতে পারে, হ্যাঁ, ট্রপাই বা ওগুলো যেগুলো দেখি আর কি, হ্যাঁ, ট্রোপোনিন। সো সিকে এন্ড সিকেএমবি বাড়তে পারে, ট্রোপোনিন বাড়তে পারে, হ্যাঁ। সো এগুলো দিয়ে আমাদের বুঝতে হবে যে মায়োকার্ডিয়াল কন্ডিশন হয়েছে, ঠিক আছে। তাহলে ট্রিটমেন্ট কি? তার ট্রিটমেন্ট মনিটর ফর অ্যারিথমিয়াস, পার্টিকুলারলি ভেন্ট্রিকুলার ইরিটেবিলিটি আর কন্ডাকশন ডিফেক্ট হয়েছে কিনা। এবার যদি অ্যারিথমিয়াস হয় তাহলে অ্যারিথমিয়া প্রোটোকলে যেভাবে আমাদের চিকিৎসা করতে হয় সেইভাবে হবে। ইটস কল্ড ACLS প্রোটোকল, অ্যাডভান্স কার্ডিয়াক লাইফ সাপোর্ট, ইটস কল্ড ACLS প্রোটোকল। ইটস আ সেপারেট কোর্স বেসিক্যালি, ACLS, okay. But usually prognosis is good. Only patients older than 50 and those with pre-existing cardiac disease, they are higher risk for significant cardiac complications. But otherwise, majority will recover. Okay. Next, diaphragmatic rupture. Right is protected by liver. Undersurface is protection আছে আর কি. Diaphragm is intimately related to the liver, না? Left এ তো হচ্ছে কোনো ইয়ে নেই, হ্যাঁ। এটা তোরা একটা প্রোটেকশন থাকলে কি হয়, তাই না? তোরা যদি একটা প্রোটেকশন থাকে, লিভারটা এরকম লেগে আছে, সো দ্যাটস ওয়াই ইজ মাচ মোর স্টেবল। বাঁ দিকে ডায়াফ্রাম, তলায় স্টমাক, সো দুদিকে ফাঁকা আদারওয়াইজ, হ্যাঁ। সো দ্যাটস ওয়াই লেফট সাইড ডায়াফ্রাম is more prone to injury. Majority cases it is left-sided injury. So blunt trauma 75% cases, penetrating trauma 25% of cases. Again, there is no distinctive signs. Just you have to think what is the mechanism of injury. Suppose a stab injury here, this side. You have to think by seeing the trajectory or কোন জায়গায় injury হয়েছে, penetrating injury, যে these patients may have associated diaphragmatic injury. ঠিক আছে? Okay. So on the left posterolateral portion of the diaphragm, that is the weakest spot and the most common site of rupture. যদি ডায়াফ্রামে রাপচার করে, প্রবলেম কি হতে পারে? না, কি প্রবলেম হতে পারে? হ্যাঁ, ঠিক আছে, ওদিকে ডায়াফ্রাম ঠিক মতো মুভমেন্ট নাও করতে পারে, ঠিক আছে। আর কি হতে পারে? ফেটে গেছে ডায়াফ্রামটা, কিন্তু ট্রান্স ডায়াফ্রাম মুভমেন্ট হতে পারে। ডায়াফ্রামটা কি করে? ইট সেপারেটস চেস্ট অ্যান্ড অ্যাবডোমেন। তাহলে কে কোথায় ঢুকতে পারে? হ্যাঁ, লাংস কিন্তু অ্যাবডোমেনে নেমে আসবে না, বিকজ লাং তো ফিক্স না, পালমোনারি আর্টারি, পালমোনারি ভেন দিয়ে তো ফিক্স। এনি ফিক্সড স্ট্রাকচারস ক্যানট কাম, সো চেস্টের স্ট্রাকচারস এখানে আসবে না। রাদার অ্যাবডোমেনাল স্ট্রাকচারস, যারা মোবাইল স্ট্রাকচারস, স্টমাক মুভ করতে পারে, কোলন মুভ করতে পারে, স্মল ইন্টেস্টাইন মুভ করতে পারে, সো দে হ্যাভ এ পোটেনশিয়াল টু এন্টার ইনটু দ্য লাংস। তারা যদি ইন্টেস্টিনাল কন্টেন্টস লাংসে চলে যায়, তাহলে এগেন কি হবে? পেশেন্টের সিমটম কি হবে? ব্লান্ট ট্রমা দেখো ডিফেক্টটা ইউজুয়ালি বড় হয়, 5 to 15 সেন্টিমিটার। পেনিট্রেটিং ট্রমাতে ডিফেক্ট ইজ ইউজুয়ালি স্মল, ওকে। তাহলে দেয়ার উইল বি হার্নিয়েশন অফ অ্যাবডোমিনাল কন্টেন্টস ইনটু দ্য থোরাক্স, ইভেন স্প্লিনও যেতে পারে, কারণ স্টমাকের সঙ্গে স্প্লিন থাকে না, সো স্টমাক ক্যান পুল দ্য স্প্লিন, হ্যাঁ। তাহলে ইট মে কজ রেসপিরেটরি কম্প্রোমাইজ, কারণ ওখানে তো শুধু লাংসের জায়গা আছে। যদি আমার সঙ্গে ইন্টেস্টাইন অ্যাবডোমিনাল কন্টেন্টস গিয়েও ঢোকে আর কি, তাহলে কি হবে? লাংসের জায়গা কমে যাবে, তাই না? লাংস কমপ্লায়েন্স তো কমে যাবে, তাহলে লাংস এক্সপ্যান্ড নাও করতে পারে। আচ্ছা, so any penetrating injury below nipple line should be evaluated for the potential of diaphragmatic injury and concurrent abdominal stab wounds to the lateral chest walls and flanks. So position তো এরকম জায়গায়, so এখানে ইনজুরি বা এখানের ইনজুরি, always think যে it may penetrate diaphragm also. There is usually a delay in diagnosis because of the associated injuries, এবং ইমিডিয়েটলি এইসব হার্নিয়েশন নাও হতে পারে। অনেক সময় ডায়াফ্রাম প্রেজেন্ট মানে ইনজুরিজ পরে প্রেজেন্ট করে, because it may take time to herniate, okay. So they are not immediately killing. So now the clinical pictures will depend on what is the size and site of injury, herniation ache kina, and associated injury ache kina. Okay. At the first moment when the injury happens, it's difficult to diagnose because normally diaphragm থেকে অত bleeding অতটা হয় না, minimal bleeding. Our patient is often asymptomatic. Okay. So acute phase কি পেতে পারো? Decreased breath sound, and you may find bowel sound in the chest. If there is herniation, you may find bowel sounds in the chest. Okay. What is this? Tension viscerothorax. What is this? What is that? Tension viscerothorax. That means it's a complication of diaphragmatic ruptures. Stomach herniates. Okay, and the stomach may rotate. It's called volvulus. It may rotate. Herniates and undergoes volvulus. Massively dilates. Because the stomach টা তো ডাইলেট করবে না, অবস্ট্রাকশন যদি ভলভুলাস হয়ে যায়, ঘুরে যায়, তাহলে তো স্টমাকটা ডিস্টেনশন হবে, ম্যাসিভলি ডাইলেট করবে। তাহলে কি করবে? It will cause left lung collapse, and again it will shift the mediastinum to the opposite side. It's called tension viscerothorax. It's a complications of diaphragmatic injury. Okay. Chest X-ray normal হতে পারে, non specific হতে পারে. Diagnostic only say 25 to 50% cases they are diagnostic. But তুমি একটা রাইস টিউব পাঠালে, এবার যদি ডায়াফ্রাগমেটিক ইনজুরি থাকে, তারপরে যদি চেস্ট এক্স রে করো, তাহলে রাইস টিউবের টিপটা নর্মালি কোথায় দেখা যায়? পেটে দেখা যায় না? এখানে কি হবে? The tip of the rice tube, ও তো রেডিওপেক মার্কার দেওয়া থাকে, that will be in the chest cavity only. Okay. So presence of nasogastric tube within the chest, it denotes a diaphragmatic injury. Okay. Ultrasound করা যেতে পারে, but small tear হলে it will miss. CT is usually a better one, or MRI. CT and MRI will show you the much better anatomy. Okay. Ultrasound sometimes doesn't give a very good pictures, but can be useful. Okay. But CT is definitely a much better. Normally you go for a CT, don't go for an MRI also, because CT is very easy to read, easily done. Okay. So after the diagnosis, if there is a confirmed diaphragmatic injury, that's an indication of surgery. Okay. Surgical repair necessary even for small tears, because any defect, any diaphragmatic defect, they are not going to heal spontaneously. So all diaphragmatic defects, they need a surgical repair. Okay. There is no spontaneous healing. You have to repair it surgically. Okay. So what are the complications? Abscess hote pare, pneumonia hote pare, diaphragmatic paralysis hote pare. Okay. So early deaths are result of associated injuries. Diaphragmatic injury per se doesn't cause immediate death. If there is early death, they are usually from associated injuries. Mortality rate কত? 25 to 40%. Because of the severity of the associated injuries. Okay. But it has the potential of developing complications if there is lots of abdominal contents going to the lungs, going to the chest cavity, causing a tension viscerothorax, mediastinal shifting. It has the potential of killing a patient. But it will give you time, it's not very immediate. That's why is it in the hidden six. Another is esophageal injury, the last. Most caused by the penetrating trauma. Okay. And cervical is more common because cervical is here, no? So any penetrating trauma, there is a very quick chance of developing esophageal injuries. Blunt is rare. Now, you suspect esophageal injuries if there is any hemothorax or pneumothorax, but there is no rift fractures. Esophageal injury হলে suppose thoracic injury হয়েছে, thoracic esophageal injury, তাহলে কি হবে? The esophageal content will come into the mediastinum. ফুড পার্টিকুলও আসবে, ফ্লুইডও আসবে, এয়ারও আসবে, বিকজ অল গাটস কন্টেন্স এয়ার। সো ইউ মে ফাইন্ড সাম নিউমোথরাক্স অর শর্ট অফ হিমোথরাক্স অর ফ্লুইড, মানে ফ্লুইড থরাক্স বেসিক্যালি, এই টাইপের পিকচার্স পেতে পারো, বাট কোনো রিফ্র্যাকচার্স নেই অ্যাসোসিয়েটেড। ঠিক আছে? Clinical symptoms will be subtle and vague. It will vary according to the site of rupture and degree of contamination. Suppose cervical esophagus will have different pictures. Thoracic esophagus will have different pictures. Abdominal esophagus will have different pictures. Thoracic কি হবে? নেকে একটা সোয়েলিং হবে, হাওয়া আসে, তাহলে ইউ ক্যান প্যালপেট, এখানে তুমি যে সাবকিউটাস টিস্যু দেখবে হাওয়া এসে গেছে, এটাকে কি বলে? সার্ভাইকাল ইসোফেগাস। হ্যাঁ, মাদিক দিয়ে তো যায় মোস্টলি। ঠিক আছে, এখানে দেখলে ফুলে গেছে এখানটা, আর প্যালপেট করলে হাওয়া পাচ্ছ, প্যাট প্যাট করে আওয়াজ হচ্ছে ক্র্যাকলসের মতো। হোয়াট ইজ দ্যাট কল্ড? সাবকিউটেনিয়াস এমফাইসিমা। সাবকিউটেনিয়াস এমফাইসিমা। সো এখানে প্যালপেট করলে দেখবে ক্র্যাকলসের মতো পট 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 আওয়াজ হচ্ছে আর কি। ইটস কল্ড সাবকিউটেনিয়াস এমফাইসিমা। ঠিক আছে। এবার যদি ইসোফেগাস মিডিয়াস্টাইনাল রাপচার হয় তাহলে কি হবে? পেশেন্ট হ্যাভ ফিচার্স অফ মিডিয়াস্টাইনাইটিস, পেশেন্ট মে হ্যাভ ফিভার, হ্যাঁ, তার সাথে হিমোথরাক্স বা নিউমোথরাক্সের মতো পিকচার্স, রেসপিরেটরি ডিস্ট্রেস, এগুলো হবে। আর যদি অ্যাবডোমেনে রাপচার করে তাহলে কি হবে? ফিচার্স অফ পেরিটোনাইটিস। সো ডিপেন্ডিং অন কোথায় ইসোফেগাস রাপচার করছে তার উপরে সিমটম উইল ভ্যারি। ঠিক আছে। So again, diagnosis depends on index of suspicions. X-ray or CT can diagnose it, and esophagoscopy also, they are reliable. So esophagoscopy combined with the esophagogram, they have 90% accuracy. Esophageal injury is initially difficult to diagnose because it's rare, and in the initial period, initial 24 hours, there may not be any clinical findings. They are slightly late development. Okay, so initially you may miss it. So any missed injury or delay in treatment results in rapid development of sepsis and associated high risk of death. Okay, so you suspect, while you cannot explain anything, always think whether the patient has esophageal injury or not. Okay, so you can go for a X-ray, CT scan, contrast CT scan, or directly esophagoscopy and esophagogram. Okay, if you suspect abdominal injury, abdominal esophagus injury, okay, the contrast material should be, দেখো দুটো চয়েস আছে, একটা হচ্ছে গ্যাস্ট্রোগ্রাফিন আর একটা হচ্ছে বেরিয়াম। ওকে, মনে রাখবে গ্যাস্ট্রোগ্রাফিন ইজ ইনার্ট ইন পেরিটোনিয়াম। ওকে, তাহলে যদি আমার অ্যাবডোমিনাল ইসোফেগাস ইনজুরি হয় তাহলে আমি গ্যাস্ট্রোগ্রাফিন দিয়ে টেস্ট করব, বিকজ লিক থাকলে গ্যাস্ট্রোগ্রাফিনটা পেটে বেরিয়ে আসবে, পেরিটোনে বেরিয়ে আসবে, অ্যান্ড গ্যাস্ট্রোগ্রাফিন ইজ ইনার্ট ইন পেরিটোনিয়াম। কিন্তু যদি আমার থোরাসিক ইসোফেজিয়াল ইনজুরি হয় তাহলে আমি বেরিয়াম দিয়ে করব, বিকজ গ্যাস্ট্রোগ্রাফিন ইজ ভেরি টক্সিক টু দ্য লাং থিং, মিডিয়াস্টাইনাল এবং লাং। ওকে, সো যদি আমার সাসপেক্টেড মিডিয়াস্টাইনাল ইনজুরি থাকে, থোরাসিক ইসোফেজিয়াল ইনজুরি থাকে, তাহলে আই উইল টেস্ট উইথ বেরিয়াম। হ্যাঁ, থিন বেরিয়াম দিয়ে করি আর কি। কিন্তু যদি পেটে ইনজুরি সাসপেক্ট করি যে অ্যাবডোমিনালে ফুটো হয়েছে কিনা, তাহলে পেটে বেরিয়াম দেবো না, বিকজ পেটে যদি বেরিয়াম যায়, লিক হলে কি হয়, বেরিয়ামটা তো ওখান দিয়ে লিক করবে পেরিটোনিয়ামে না। পেরিটোনিয়াম, বেরিয়াম ইজ ভেরি মাচ পেরিটোনাল ইরিট্যান্ট। ওখানে ইনার্ট হচ্ছে, পেটে ইনার্ট হচ্ছে গ্যাস্ট্রোগ্রাফিন, আর চেস্টে ইনার্ট হচ্ছে বেরিয়াম। সো কোথায় ফুটো হচ্ছে তার উপরে আই উইল চেঞ্জ মাই কন্ট্রাস্ট মিডিয়াম। একটা কন্ট্রাস্ট দিতে হবে তো দেখতে গেলে, ইসোফেগ্রাম করতে গেলে। ঠিক আছে, সো ডিপেন্ডিং অন দ্য সাইট অফ ইনজুরি will change our contrast medium, and you have to treat very aggressively. Okay, so patient has to be, you have to suspend all the oral intake, place an nasogastric tube, antibiotics. Jodi chest correction hai tale you have to give chestwound therapy, and then you have to go for a surgical therapy. So this is a deadly dozen. Each of these injuries, if you divide into lethal and hidden, lethal are immediate life threatening, immediate. If you don't address, they will die immediately. And the hidden gives sometimes, but if you don't address, ultimately it will lead to death. Esophageal injury, if it's a missed esophageal injury, There may not be initially 24 hours, 40 hours may not be anything, but then the patient will develop into sepsis and all these, then multi-organ failure, then they will get into a vicious cycle and may die. Okay. So mechanism of injury is the most important. Always think how the injury happened, and from that you have to extrapolate that these patients may have. Patient don't tell me I have severe injury. Patient will tell you, huh? Patient won't tell. Patient will say, "Dibbi achi," huh? But you have to think from the mechanism of injury that these patients may not be right. You have to pick it up. So you have to do investigations accordingly. Okay. So you have to recognize the signs and symptoms, and from the mechanism of injury, you have to extrapolate that this is a potential data hote pare. Until unless you think jeta hote pare, you cannot investigate that way.
The most important part, calcium, vitamin D, how the vitamin D is changed, and the different types of the parathyroid hormone substitutes like teriparatide we have discussed. Today we will start with the calcitonin. So now we will start with the calcitonin. Previously we have already seen everything about the parathyroid gland. What is hypoparathyroid, hyperparathyroid, how the parathyroid hormone as a controls the calcium, vitamin D metabolism, all we have discussed. So this is very important. Already in the previous class we have discussed. Time and again I am saying this is very important. Okay, how it is controlled, how the hypocalcemia, when there is hypocalcemia, how the parathyroid hormone changed it to a normal calcium balance in the plasma. Now coming to the calcitonin. So calcitonin is basically a peptide hormone which is secreted by the parafollicular or C cells lying in the interstitial fluid between the follicles of the thyroid gland. So parathyroid hormone is secreted from the parathyroid gland, and this parathyroid gland is present posterior to the thyroid gland. But calcitonin is secreted from the thyroid gland itself. Within the thyroid gland there are parafollicular cells or C cells. From these parafollicular cells calcitonin is secreted. This is a 32 amino acid single chain peptide with a disulfide bridge, and it tends to decrease the plasma calcium concentration. So you can remember that the action of the calcitonin is just opposite of the parathyroid hormone. Okay. So parathyroid hormone always tries to increase the plasma calcium level, while calcitonin tends to decrease the plasma calcium concentration, and in general has effects opposite to those of the parathyroid hormone. Okay. Calcitonin is the most potent peptide inhibitor of the osteoclast mediated bone resorption. So osteoclast ultimately causes bone resorption, and this calcitonin hormone is the most potent peptide inhibitor of this osteoclast mediated bone resorption, and it helps to protect the skeleton during periods of the calcium stress. Calcium stress means when more calcium is needed for maintaining the bone architecture, like during the growth period in the children, in the pregnancy and in the lactation phase. In those cases, more and more calcium is needed so that there will be more calcium may be available in the plasma. So calcitonin basically tries to maintain a balance so that the bone resorption will not be more, so that it maintains the normal bone architecture in the period of the calcium stress. This is the action of the calcitonin. Synthesis and secretion of the calcitonin is regulated by the plasma calcium concentration, like that of the parathyroid hormone. Here just the opposite. When there is rise in plasma calcium, it increases, and while fall in plasma calcium decreases the calcitonin release. Just opposite of the actions of the parathyroid hormone. Circulating level of the calcitonin is low, and its physiological role in regulating plasma calcium appears to be minor. So in physiology, very minute amount of the calcitonin is secreted and its role is minor, but its role becomes major when there is calcium stress period comes, so that it maintains the bone, so that there will be no more bone resorption. If there is more bone resorption than the bone development, there will be more chances of the osteoporosis. So in this way it helps in the osteoporosis. The plasma T-half of the calcium is 10 minutes, but its action lasts for several hours. Calcitonin decreases plasma calcium concentration rapidly within minutes after injection of the calcitonin. So this is the actions already we have discussed. So it inhibits the bone resorption by direct action on osteoclast. It acts directly on the osteoclast cells in the bone, inhibits the proximal tubular reabsorption of the calcium and phosphate by direct action on the kidney. In the kidney, there is also receptors for the calcitonin where it directly acts and ultimately inhibits the proximal tubular reabsorption of the calcium. Just the opposite actions of the parathyroid hormone. Action is mediated through the G protein coupled calcitonin receptor and increased CMP formation, but target cells are different from the parathyroid hormone. Parathyroid hormone target cells and the calcitonin target cells are different, but ultimately the actions are just opposite to one another. These are the preparations of the calcitonin that is available. Porcine or natural calcitonin is quite antigenic, that's why it is not used nowadays, because if it becomes more antigenic, that may lead to more chances of the allergic and hypersensitivity reaction. We are now using the synthetic salmon calcitonin. So this calcitonin is obtained from the salmon fish. More potent and longer acting due to slower metabolism. Synthetic human calcitonin, 1 international unit means 4 microgram of the standard preparation. It is given by the subcutaneous or intramuscular routes, but nowadays in most of the calcitonin is given as nasal spray. So salmon calcitonin is also available as nasal spray, and now it is the main modes of drug distribution to the humans. So if you are asked that name one example of a drug that can be given as a nasal spray, this is one example. So salmon calcitonin nasal spray. It uses hypercalcemic states, just the opposite of the parathyroid hormone. When there is hypercalcemia, hypercalcemia can happen due to the hyperparathyroidism. In the previous class we have seen when the parathyroid, there may be most common cause of the hyperparathyroidism is some parathyroid tumor. So from the tumor, more amount of the parathyroid hormones are secreted. That tends to increase the plasma calcium level. So that leads to hypercalcemia. Similarly, that is also seen in case of the hypervitaminosis D, when vitamin D is given more. Osteolytic bony metastasis, that is cancer is present, and this become metastasized to the bones, and ultimately the bones are broken down. That leads to more calcium availability in the plasma. So this is the osteolytic bony metastasis. Hypercalcemia of the malignancy. In malignancy, there is always chances of the hypercalcemia, more calcium in the blood. So in these cases, we can use the calcitonin to decrease the plasma calcium level. When it is given, it acts rapidly within 4 hours, response peaks at 48 hours, and then refractoriness develops. It also relieves the bone pain, because in cancer, if there is osteolytic metastasis, there will be severe bone pain, and that bone pain can also be reduced when we are using calcitonin, mostly by calcitonin nasal spray. Paget's disease of the bone, this is a disease of the bone where there is increased skeletal remodeling. So skeletal remodeling, that is the bone development and bone resorption. Already we have seen that this is a cycle. When this cycle is disrupted, there may be some problems. One of these problems is the Paget's disease of the bone. Here we can use the calcitonin. Apart from this, it is used in postmenopausal osteoporosis, corticosteroid-induced osteoporosis. It can be used as a diagnostic tool also for diagnosis of the medullary carcinoma of the thyroid. Detection of the high blood levels of the calcitonin is diagnostic of this tumor. So this is one of the biochemical marker of the medullary carcinoma of the thyroid. In medullary carcinoma of the thyroid, the parafollicular cells becomes hyperplastic, and that secretes more calcitonin in the blood. That's why we can detect that there is some medullary carcinoma of the thyroid may be present. Adverse effects, some flushing, tingling sensation of fingers, altered taste, flu-like symptoms, joint pain, allergic reaction, etc. can occur. Some interference with digoxin, which is a cardiovascular drug, can also happen. Fibroblast growth factor 23. Next, details is not required. Just remember, FGF23 is basically fibroblast growth factor 23 that helps in the development of the osteoblast, osteocyte, and lining cells. Main function is the promotion of the urinary phosphate excretion, which is a hypophosphatemic hormone. and the suppression of the active vitamin D production by the kidney. And apart from this, there is another membrane protein known as the clotho. Okay, this is an essential cofactor in the transduction of the FGF23 signaling. Basically, these are now tested in the laboratory for the development of the newer drugs that helps in the osteoporosis and other diseases of the bone. Details is not required, just remember the name, that these entities are there and this is being researched. Next, coming to the bisphosphonate. Bisphosphonate is very important for your exam. It can come as a part of the long question as a short note in the viva, etc., etc. It is a very common question. So bisphosphonate is now one of the most important and mainstay of the treatment of osteoporosis. It is a non-hormonal agent used in calcium homeostasis. These agents, this bisphosphonate, basically form a three-dimensional structure that capable of chelating divalent cations such as calcium and have a strong affinity for bone. Within the bone, we know there are different types of the minerals, most commonly the hydroxyapatite. This bisphosphonate have affinity towards this hydroxyapatite, and when we are giving the bisphosphonate, this bisphosphonate goes within the bones and attaches with this hydroxyapatite. Prevents osteoporosis and useful in metabolic bone disease and hypercalcemia also. Most effective anti-resorptive drug at present, that is, it prevents the resorption of the drug. So this is the bisphosphonate structure. What happens? These are the analogs of the pyrophosphate. So this is the pyrophosphate. There are two phosphate atoms are there. That contains two phosphate groups attached to a geminal or central carbon. Okay. So this O is replaced by another carbon. This pyrophosphate is converted to bisphosphonate. Replaces the oxygen in the pyrophosphate. There are two side chains. You can see R1 and R2. R1 side chain affects the binding affinity to the bone. So if we are changing the R1, so different bisphosphonates can come, and accordingly the binding affinity to the bones also differs. So this differs according to the side chain R1 that binds with the geminal or central carbon of this bisphosphonate ring. This is the bisphosphonate ring that develops due to the changes of the pyrophosphate, where the geminal oxygen atom is changed to geminal carbon atom. R2 is the another side chain that affects the anti-resorptive capacity. So how much anti-resorptive capacity of a bisphosphonate is there depends upon the R2 side chain. So this R1 and R2 can be changed with different atoms, and accordingly different bisphosphonate drugs can be discovered. So possibly the side effect profile also can develop this R2, okay, because the anti-resorptive potential also if this is increasing, the side effect profile of the bisphosphonate is also increasing. So bisphosphonates vary in potency based on the specific side chains. So according to their structure, the changes in the different bisphosphonate among the side effects, among the anti-resorptive capacity, among the affinity, all these changes can happen due to this R1 and R2 side chain. Now coming to the generations of the bisphosphonate. The previous generations, the older ones are known as the first generation. Then the newer ones like second generation and third generation came. Again, all these generations came due to the different types of the side chains. First generation are the simpler side chain, etidronate and teludronate. But the relative potency, you can see the one, etidronate is the minimal potency bisphosphonate. Teludronate is 10 times more potent than the etidronate. Then the second generation bisphosphonate came, where the side chains contain either amino or nitrogenous. Amino and nitrogenous side chains are there. Example is pamidronate, alendronate and ibadronate. You can see the relative potency is very high, approximately 100 times or 100 to 500 times or 500 to 1000 times than that of the etidronate. That is more and more potency. That is with very little amount of the drug, the affinity of the drug will be more for the bones, so that the anti-resorptive capacity will be more. The third generation is the recent ones, where the anti-resorptive capacity and the potency is very high. You can see risedronate and zoledronate approximately 1000, and zoledronate is the most potent bisphosphonate, 5000 times more potent than the etidronate. So with each successive generation, there has been increased potency with more selectivity for inhibition of resorption and less inhibition of the bone formation. So all these are due to the changes in the side chain R1 and R2. R1 and R2. Okay, R1 is mainly for the affinity towards the bone. Bisphosphonate attaches with the within the bone minerals, and R2 according to their anti-resorptive capacity as well as the side effects. So first generation bisphosphonate contain minimally modified side chains or possess a chlorophenyl group and are the least potent agents, lesser used nowadays. Second generation bisphosphonate, alendronate and palmidronate. Alendronate is very commonly used nowadays, contain a nitrogen group in the side chain 10 to 100 times more potent than the first generation compounds. Third generation is the risedronate and zoledronate. Both the risedronate and zoledronate are used, contains a nitrogen atom within a heterocyclic ring and up to 5000 or even 10,000 times more potent than the first generation agents. That's why it can be given like zoledronic acid can be given 1 in 6 monthly like this. That is, in the 6 months only 1 injection of the zoledronic acid can be given because it is very much potent, approximately 5000 to 10,000 times than the first generation bisphosphonates. So how the bisphosphonates acts, mechanism of actions? So they have selective affinity for the calcium phosphate. So within the bones, there are bone minerals. Within the bone minerals, there are calcium phosphate and different other hydroxyapatite minerals. So they have selective affinity, and this affinity also depends according to their generations, already we have seen. So calcified tissues and direct inhibitory effect on osteoclast. When they enter within the bones there are osteoblast cells and osteoclast cells. They directly acts on the osteoclast and inhibits the bone resorption. There are two components of the bone matrix and solid mineral phase. Solid mineral phase is the hydroxyapatite. You can revise this in the physiology and anatomy also. So what is how the bone is structured? Within the bone there is one matrix phase, another is the solid mineral phase. Solid mineral phase is the hydroxyapatite. Normally the non-mineralized osteoid covers the mineralized bone matrix, preventing its resorption by osteoclast. This is in normal times. When the time of the bone resorption comes, then this cover ultimately put off. But normally when there is only bone development but no bone resorption, there are some non-mineralized osteoid are there that covers the mineralized bone matrix and prevents its resorption. Now for resorption, these osteoids must get dissolved so that there will be no covering, and the mineralized or solubilized items, so this becomes exposed to the osteoclast cells, and these osteoclast cells ultimately causes bone resorption. And when the bone resorption happens, so that there will be more calcium influx occurs within the plasma. So basically this is a cycle. So in this occurs due to the presence of the resorptive pits. So there are some areas that is known as the resorptive pits where this exposure of the osteoclast cells happens. So in this resorptive pits, acidic zone is created at ruffled borders of the osteoclast, and that is followed by resorption of the matrix by acid hydrolysis. So different types of the enzymes like acid hydrolysis are secreted, and this ultimately causes bone resorption, that is bone destruction in other words. But it is not destruction, it is called resorption because this is basically a cycle, bone resorption and bone development. Bisphosphonates localize in this acidic zone. In this resorptive pit within the acidic zones, bisphosphonate comes and attaches mainly with this solid mineral phase, hydroxyapatite, so that these osteoclast cells cannot expose to this acid hydrolysis. The solid mineral phase are not exposed to these osteoclast cells, so that the resorption of the bone is inhibited. Bisphosphonates localize in the acidic zone due to high affinity for their calcium ions, because this affinity again it varies from generation to generation. Calcium ions released from the bone surfaces due to high acidity, and bisphosphonates are also released, internalized into osteoclast by endocytosis. So ultimately it is endocytosis. So ultimately when it is given, it results in accelerated apoptosis of the osteoclast, reducing their number. So when this bisphosphonate is given, these osteoclast cells cannot act their own works, and this becomes internalized by endocytosis. That causes accelerated apoptosis. So apoptosis means programmed cell death. So it becomes apoptosis. Some osteoclast becomes apoptosis. Disruption of the cytoskeleton of the ruffled border of the osteoclast. All this leads to osteoclast destruction, so that the bone resorption is inhibited and there will be bone development is going on. So this is the mechanism of action of the bisphosphonate. So bisphosphonate mechanism in short, so they have high affinity towards the mainly the calcium phosphate and the hydroxyapatite, that is the solid mineral phase of the bones, and this affinity mainly depends on their side chains, and this changes from one generation to another generation. When it enters within the bones, they come resorptive pits. Resorptive pits are the areas, these are the acidic pH areas where the osteoclasts are exposed to the solid mineral phase of the bones. But when this hydroxyapatite comes, that gives a covering on this so that the osteoclast cannot get exposed to this solid mineral phase. So ultimately the osteoclast cannot do the bone resorption activity, and ultimately when it is continual coverage, that leads to programmed cell death or apoptosis of these osteoclast cells as well as destruction of their ruffled borders. Pharmacokinetics, now these bisphosphonates are very poorly absorbed from the intestine and they have remarkably limited bioavailability. You can see the bioavailability is less than 1% to 6%. So bioavailability of the bisphosphonate is very low. Hence this drug should be administered with a full glass of water followed by an overnight fast and at least 30 minutes before breakfast will come, because these bisphosphonates are very dangerous for development of the different esophageal problem, esophagitis, esophageal irritation, gastric ulcer, all these can develop. If we have to prevent these adverse effects, we have to follow the specific guidelines of the bisphosphonate treatment. One of these is the patient should take an overnight fast. In the first morning, the patient have to take this bisphosphonate in an empty stomach with a full glass of water in an upright posture, and then again another full glass of water is to be taken, and the patient should not lie down for approximately 30 minutes to 1 hour after taking the bisphosphonate tablet. The patient should not take any other drugs within this 1 hour after taking the bisphosphonate tablet. Okay. So oral bisphosphonates have not been used widely in children and adolescents because of uncertainty of the long-term effects of the bisphosphonate on the growing skeleton. Because these bisphosphonates are very much very good affinity towards the bones, they are lodged within the bones. So we do not know in case of the children and adolescents where there is growing bones, if they are lodging within these bones, that ultimately leads to any detrimental effect or not. That's why it is given only in adults. Bisphosphonates are excreted primarily by the kidneys and are not recommended for patients with chronic kidney disease. That is when the creatinine clearance is less than 30. So if the kidney fails, we should not give the bisphosphonate because they are excreted primarily by the kidneys. Therapeutic uses where it is used, osteoporosis. Now the main anti-resorptive drug that is used for osteoporosis is the bisphosphonate. Prevention and treatment of the postmenopausal osteoporosis, because most of the osteoporosis patients we are seeing the postmenopausal osteoporosis. That's why time and again it is told that the postmenopausal osteoporosis. Apart from this, there is also senile osteoporosis. There may be some drug related osteoporosis. Most common, the corticosteroid induced osteoporosis. In all these cases, bisphosphonate is used. Paget's disease, here it is used. In Paget's disease, there are mainly honeycomb-like bone architecture. Honeycomb, that is within these bones, there will be spongy appearance of the bone cells. They arrest these osteolytic lesions, reduce bone pain and improve secondary symptoms. Hypercalcemia of the malignancy. Calcitonin is used, and also this bisphosphonate can be used in the hypercalcemia of malignancy and osteolytic bony metastasis. Same thing. Calcitonin is also used, and again bisphosphonates are used when there is metastasis occurs from the different cancers to the bones. Etidronate not used nowadays. Pamidronate is mainly given IV. 2 to 4 hours, 60 to 90 milligram weekly or monthly in Paget's disease and hypercalcemia. Alendronate is the oral drug. Alendronate can be given as a oral tablet. 5, 10, 35 or 70 milligram is there, mainly used for the prevention and treatment of the osteoporosis. Already we have discussed about this. Bioavailability is very less. Risedronate is more or less similar, but it is more potent. Zoledronic acid is the parenterally effective. It is given by parenteral route. No oral route is there. It is highly potent, usually given 6 monthly. Suppression of the osteoclastic activity and additional anti-tumor effect is also there. Proliferation of the bony metastasis of the prostate and breast cancer cells are suppressed. Because this osteolytic bony metastasis most commonly occurs with prostate cancer. So, prostate cancer in males usually metastasize within the bones, and that leads to very dangerous bone pains also. In those cases, if we are using this zoledronic acid, that also decreases the progression of this tumor, prostate as well as the breast cancer cells. Can be infused in 15 minutes. Flu-like symptoms can happen when we are injecting the zoledronic acid because some cytokine release can occur. Adverse effects, already I am saying that oral bisphosphonate mainly causes different types of the gastrointestinal symptoms, gastrointestinal irritation. Like there may be some gastritis, gastric ulcer, esophageal irritation, esophagitis, abdominal pain, nausea, vomiting, diarrhea, constipation, all this can happen. To minimize this, we have to follow. That is, patients should remain upright, sitting or standing for at least 30 minutes after taking the medication. Apart from this, bisphosphonate related osteonecrosis of the jaw or phossy jaw can happen. This is a rare side effect. Osteonecrosis of the jaw can happen. Another rare side effect is the atypical fracture of the femur. In the proximal 1/3 of the femur, atypical fracture of the femur can happen due to the long-term bisphosphonate use. Very rare but very dangerous osteonecrosis of the jaw or phossy jaw can happen due to the bisphosphonate. Initial parenteral infusion can lead to flushing, flu-like symptom, muscle and joint pains. Zoledronate can cause severe hypocalcemia, has been associated with renal toxicity, deterioration of the renal function and potential renal failure. All can happen. So this is already we have discussed. So this is very important, that how the bisphosphonate tablets should be given. The same thing again I am giving this. So patients should be informed and be able to follow strict administration guideline. If not, there will be severe esophageal irritation, severe gastric ulceration, and the patient cannot continue the bisphosphonate. So tablets must be swallowed whole. It should not be crushed or it should not be chewed, so that there will be no free portions will be in touch with the esophagus, because that ultimately leads to esophageal irritation. With a full glass of water on an empty stomach at least 30 to 60 minutes before food. That is, after taking the tablet, after 1 hour the patient can take any drug or any food, and while standing or sitting upright. So the patient should not lie down for approximately 30 to 60 minutes after taking this bisphosphonate tablet. Patient must not lie down after administration. Patients should be advised to stop the bisphosphonate tablets and seek medical attention if any signs of the esophageal irritation, that is some burning sensation or some dysphagia can develop. The patient have to stop this bisphosphonate tablet. So how the bisphosphonate tablet, most commonly the alendronate, should be administered? This is very important. What are the precautions should be followed? Osteoporosis, already from the first day I am telling that osteoporosis. What is this? It is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue. That is, within the bone tissue the architecture is deteriorated. That leads to bone fragility. The bones become more predisposed to fractures, and this may be caused due to the primary or secondary causes. Primary may be postmenopausal or senile, that is due to the age most commonly. In postmenopausal it happens because the estrogen action diminishes. Estrogen restores bones. So with diminished estrogen action, there will be more osteoclastic activity without any increase of the osteoblastic activity. That's why postmenopausal osteoporosis is so common. In the age-related or senile cases, also similar types of the thing happens. Secondary osteoporosis means that happens secondary to some disease or some drugs. There are different types of the diseases. For example, acromegaly, Addison's disease, amyloidosis, COPD, hemochromatosis, hyperparathyroidism, different cancers like lymphoma, leukemia, malabsorption state, multiple myeloma, multiple sclerosis, rheumatoid arthritis, sarcoidosis, severe liver disease, thalassemia, thyrotoxicosis. These are the common diseases that also leads to osteoporosis. So when we are treating this type of the diseases, we should also check the bone mineral density. Usually the osteoporosis is diagnosed by checking the bone mineral density, BMD. And there are different types of the scores like FRAC scores, etc. From this we can develop some scores, and accordingly if the scores is below 2 or 2.5 standard deviation than the normal, then we can tell that the patient have osteoporosis. And if it is between 1 standard deviation or 1.5 standard deviation than the normal individual, the bone architecture, we can say that the osteopenia is present. That is the precursor of the osteoporosis, osteopenia. That is the bone architecture is getting deteriorated, osteopenia. So we should start treatment, and ultimately when it becomes deteriorated, osteoporosis develops. These are the different drugs. The most common is the glucocorticoids, because we have to use the glucocorticoids or corticosteroid for different types of the diseases. Most common rheumatoid arthritis, and if we are continuing steroids for the long period of time, particularly in a high dose, that leads to osteoporosis. Apart from this, anticonvulsant drug, excessive thyroxine, heparin, lithium, GnRH agonist, all can lead to osteoporosis. Bone physiology, I am not going into the details. You can read this in your physiology and as well as the anatomy, so that it will be clear that where the bone what is the bone physiology and how it getting deteriorated when there is osteoporosis. So remodeling, time and again, remodeling, bone resorption and bone development goes side by side, and this is done by the bone remodeling units. Osteoclast production, osteoclast basically getting activated by the osteoblast cells itself, and this activation done by means of a receptor. This is known as the rank receptor for activating NF kappa beta rank, and there are some ligands known as the rank ligand. So all these are needed. So you can see osteoblast produce osteoprotectin. So this is the osteoprotectin is the common ligand that inhibits the osteoclast production by competing effectively with rank ligand for binding to the rank. So we can see this is the rank ligand. This is the osteoblast cells. Osteoblast cells, this is the rank ligand. When it attaches with the osteoclast precursor cells, the osteoclast becomes activated. When the osteoclast is activated, this is the activated. You can see this is the ruffled border of the osteoclast where the bone resorption happens. But this activation will not happen when there is osteoprotectin. Osteoprotectin is the normal physiological protein that is present, that attaches with this rank ligand and inactivates this. So when the time comes for the bone remodeling, the osteoblast cells, the osteoprotectin ultimately goes away. The osteoblast cells attaches with the osteoclast cells, and osteoclast cells becomes activated for the bone resorption. And again the bone development happens. This is a cycle. So you can see this is the cycle. This is the resting stage, activation, then occurs resorption, then again occurs formation of the bones, then secondary mineralization. After the bone formation, minerals are getting into it, and then remodeling completed. So this is done within this resorptive pits. This is mainly acidic pH. This is also known as the bone remodeling units. So normal bone remodeling is a balance of bone resorption and formation. What I am saying time and again. So this is the osteoclast precursor cells. Osteoclast is activated, then causes bone resorption, then osteoblasts are activated, that leads to bone formation, and then this one cycle is completed, and again this cycle is continuing. So you can see the time period, approximately 2 to 4 weeks is needed for activation to resorption of the bones, and approximately 3 to 4 months is needed for the complete mineralization of the bones. So approximately one cycle usually stays for approximately 4 to 5 months. Okay. So osteoporosis happens when this resorption exceeds the formation. So when the balance is lost. So you can see here the bone formation happens. That's why it becomes similar to the previous. But here there will be more bone resorption because the osteoclast cells are more proactive, but the osteoblast cells are less, and osteoblast cells are not active so much. So that there will be fragile. So there will be resorption is present. So the bones becomes narrower. So ultimately when this happens, resorption exceeds formation, osteoporosis occurs. So our treatment options of all these drugs is either inhibition of the resorption or the stimulation of the bone formation. Both of these can be done. So these are the drugs used in osteoporosis. Some are anabolic agents, that mainly helps for bone growth and development. Some are anti-resorptive agents that mainly helps to decrease the resorption of the bones. It forms new bone, it suppresses bone resorption, it increases the osteoblastic activity, it decreases the osteoclastic activity, it accelerates turnover, it slows turnover of the bones, it forms new bone, increase bone volume, it increases the mineralization of the existing bone. For example, teriparatide already we have discussed, which is a parathyroid hormone analog, which is basically an anabolic agent. Apart from this, fluoride is there, lesser used nowadays. Androgen hormone, because when there is hypogonadism, that becomes the androgen hormone level is less in humans. That also leads to osteoporosis, because androgen is very effective in bone formation. So androgen is also an anabolic agent. And within the anti-resorptive agent, bisphosphonate is the most important anti-resorptive agent. Calcitonin, estrogen replacement therapy, ACRMs, already you have read about the ACRM, selective estrogen receptor modulator, tamoxifen, raloxifene, you have already read. So within tamoxifen is mainly used in breast cancer and raloxifene is mainly used in osteoporosis. So again, the selective estrogen receptor modulator, which you have read in the sex hormone chapter, which can be of this, the raloxifene is used in the treatment of the osteoporosis. Calcium, vitamin D, and in some of the cases thiazide can also be needed. Strontium granulate is another drug which is basically dual action. Both of these actions are there. First, coming to the thiazide diuretic, it is a diuretic, but it has been seen that it reduces the urinary calcium excretion and constant bone loss in patients with hypercalciuria. So if you have asked that any diuretic can have action on the bones or can have some anti-osteoporotic action, so this is the answer, thiazide diuretic. Strontium granulate is a ranelic acid salt of the strontium. Strontium is an element. Oral strontium granulate is an alternative oral treatment belonging to a class of drugs known as the dual action bone agents. Dual action means it also decreases the bone resorption and increases the bone formation. It has proven efficacy especially in the prevention of the vertebral fracture. So when there is fracture occurs in the vertebra. Mechanism of action, it increases the collagen and non-collagen protein synthesis, enhances pre-osteoblast differentiation, that is the precursor of the osteoblast differentiation is increased and decrease osteoclast function. Dose is usually 2 gram oral suspension daily, but adverse effect is the thromboembolism, because they can causes the thromboembolism. That's why the strontium granulate is lesser used nowadays. Fluoride is another element that increases the bone volume and trabecular bone mineral density by increasing the osteoblastic activity. Sustained release fluoride is associated with lower blood fluoride levels and have shown favorable results on the fracture incidence. But again, it is lesser used nowadays because good drugs are there. Denosumab is used nowadays, but it is somewhat costly. Denosumab is a monoclonal antibody, which is a human monoclonal antibody that inhibits the rank ligand. So already we have seen about how the osteoblast activates the osteoclast. So osteoclast precursor cells that becomes activated when the osteoblast cells attaches with it and activates. Normal, there is rank ligand and it is attaches with the proteogreen. So you can see osteoproteogreen is a normal protein that binds with this rank ligand so that the osteoblast cannot activate this osteoclast. But when there is bone resorption is needed, the osteoblast cells attaches with this rank ligand to the rank and osteoclast cells becomes activated. So what happens, this denosumab rank ligand binds to its receptor rank on the surface of the precursor and massive osteoclast and stimulates these cells to mature and resorb bones. Already we have discussed. This osteoproteins competes with this rank for binding to rank ligand and is the physiological inhibitor of the rank ligand. And this denosumab is a human monoclonal antibody that binds with high affinity to this rank ligand, mimicking the effect of the osteoprotectin. So the osteoprotectin is the normal physiological protein, and we are just making one monoclonal antibody that acts like osteoprotectin. Like osteoprotectin, it attaches with the rank ligand on the osteoblast so that this rank and rank ligand cannot attaches with the osteoclast and the osteoclast will not be activated. So they are like osteoprotectin mimics this denosumab. So this denosumab blocks the osteoclast formation and activation, increases bone mineral density, decreases bone turnover markers. This denosumab is given subcutaneous route, usually given 60 mg once every 6 months. Again, it is given 6 monthly. The same thing what I am discussed already. I say. So this is the osteoblast cells, and this is the rank ligand. The blue ones is the rank ligand. Okay, and the red one is the rank. Rank is the receptor. And this rank ligand attaches with the rank so that the activation of the osteoclast happens. And now this osteoprotectin is the pink one. This osteoprotectin is the normal physiological protein that attaches with this rank ligand so that this rank ligand cannot attach with the rank. Rank means is a receptor. Okay. So when this happens, so osteoclast resorption will not happen. So when we are using denosumab just acts like that of this osteoprotectin. So you can see this is the monoclonal antibody denosumab. The copy in color ones did acts like that of this pink color ones. So they also attaches with this rank ligand so that this rank ligand will not be free. This rank ligand will not attaches with the rank receptor on the osteoclast, and that ultimately leads to this osteoclast cells will not be activated for the resorption of the bones. So this is the action of the denosumab. So it is clear. So it is clear. So denosumab mainly acts as a osteoprotectin mimicker. Osteoprotectin is a normal agent that is present in our body, and denosumab is a monoclonal antibody that is discovered and that is prepared in the laboratory. Okay. Now coming to the sclerostin. Sclerostin is a small protein, another protein expressed by the SOS2 gene in the osteocyte. So besides osteoblast and osteoclast cells, there is another cells, that is the osteocyte cells. This is present on the osteocyte cells, bone cells that respond to mechanical stress applied to the skeleton and appear to play an important role in the regulation of the bone remodeling. So the main players of the bone remodeling are the osteoblast and osteoclast cells, and the osteocyte cells basically modulates this whole bone remodeling. And sclerostin is a small protein that is expressed by these osteocyte cells. When this sclerostin binds to its receptor on the cell surface of the osteoblast, a downstream cascade of the intracellular signaling happens with the ultimate effect of inhibiting osteoblastic bone formation. So when this sclerostin becomes activated, that inhibits the osteoblastic bone formation action. So sclerostin is basically inhibiting the osteoblastic bone formation. So you can see this is the sclerostin, this is the mesenchymal stem cell or osteoprogenitor cells from which the osteoblast cells are formed. From the pre and then pro osteoclast cells are formed. Rank ligand, already we have seen rank ligand. When the rank and rank ligand comes together, the osteoblast cells activate the osteoclast, and here comes the sclerostin. Sclerostin is present in the osteocyte cells that basically blocks, this is the blockade sign, that blocks the osteoblastic bone formation. And this happens when there is mechanical unloading and estrogen deficiency. Mechanical unloading and estrogen deficiency happens, the sclerostin becomes more activated, that blocks the osteoblastic bone formation. And it also stimulates the rank ligand expression. So when more rank ligand expression happens, that attaches with the rank, and that ultimately leads to more osteoclast expression, more osteoclast action, more bone resorption. So the same thing, osteocyte unloading, so sclerostin ultimately blocks the osteoblast bone formation and it causes more osteoclast bone resorption. So what happens if we can develop one antibody that acts against sclerostin, so anti-sclerostin antibody, so that can blocks the sclerostin, so that this blockade on the osteoblast will not happen and the more osteoclast bone resorption will not happen. So it is clear. So like denosumab is a monoclonal antibody that acts like the osteoprotectin and that ultimately blocks the rank ligand rank binding, and this is another antibody that is acts on the sclerostin. Sclerostin is basically expressed by the osteocyte cells and that causes less bone formation, more bone resorption. So if we develop one antibody against this, that blocks all this action. So this is known as the romosozumab. Romosozumab is the newest one that is used for the treatment of the osteoporosis. Romosozumab is an anti-sclerostin antibody. It is a sclerostin inhibitor. Is the first new approach to the treatment of the osteoporosis and fracture risks in almost a decade. So after a long period of the time, there is a new drug come. This is known as the romosozumab. It significantly and rapidly increases the bone mineral density in both the lumbar spine and total hip and in both trabecular and cortical bone, leading to an increase in bone strength and reduced risks of fracture. In clinical trials, it shows better results than other treatments, but the problem is it may increase the risk of myocardial infarction and stroke. So one of the drawbacks of the romosozumab that it increases the heart attack and stroke risk. So we have to balance the pros and cons. So those persons who have some history of the ischemic heart disease, so we should not give the romosozumab. But in those persons where there is no history of the heart disease, we can give the romosozumab. Romosozumab is an anti-sclerostin antibody that ultimately helps in the bone formation and decreases the bone resorption. Glucocorticoid induced osteoporosis. Time and again saying that glucocorticoid is the most common drug that leads to osteoporosis. It inhibits osteoblast function and increased osteoblast apoptosis, stimulates bone resorption, impairment of the absorption of the calcium across the intestine, increase of the urinary calcium loss. It also induces secondary hyperparathyroidism, reduces adrenal androgens, suppression of the ovarian and testicular secretion of the estrogen and androgens, induction of the glucocorticoid myopathy. All this leads to glucocorticoid induced osteoporosis. So we have to treat the glucocorticoid induced osteoporosis, and the most important treatment is the bisphosphonate. Only bisphosphonate is most effective against this osteoporosis. Control trials have shown that there is better result. Apart from this, we can use the thiazide diuretic. Parathyroid hormone and teriparatide can be used in some of the cases. So remember, when you are asked what is the treatment of the corticosteroid induced osteoporosis, bisphosphonate is the answer. So this is the different types of the guidelines are there. So this is one guidelines. So when there is high risk of the fractures, there may be spine porosis or hip porosis. Spine porosis, that is the bones become fragile within the spinal column. So we should use teriparatide 20 microgram daily for 2 years, followed by some anti-resorptive therapy. Anti-resorptive means some bisphosphonate. When there is hip porosis, we should try with the zoledronic acid 4 to 5 milligram yearly, and after 3 years we have to reassess. Or we can use the denosumab 60 milligram every 6 months. Denosumab is a monoclonal antibody, already we have seen, which is a osteoprotectin mimicker, which ultimately blocks the rank ligand combinations. Oral alendronate can be given 70 milligram once a week for 3 to 5 years. Again, we have to reassess. When the fracture risk is low to moderate, we should not have to use the anabolic agents like teriparatide. We can use the alendronate, zoledronate and denosumab. Okay, all these agents can be used. So this is the way by which we can treat. Prevention of the osteoporosis. Osteoporosis can be prevented if we do the regular physical activity adequate dietary calcium intake. In case of the elderly, increased dietary calcium and vitamin D supplementation, timely administration of the estrogen, and prevention and correction of the hypogonadism. So in the sex hormones chapter, you have already read about the estrogen, ACRM as well as the androgens. These three agents are also useful for the treatment of the osteoporosis. So if you are asked what are the management and what is the treatment options of the osteoporosis, you have to tell everything from the calcium, vitamin D, from the teriparatide, that is the vitamin parathyroid analog, to the denosumab, romosozumab, calcitonin, from to the ACRM, estrogen, androgens, strontium randylate, thiazide, etc., all these. So ACRM, I am just telling again for the revision. So there are two selective estrogen receptor modulator. This selective estrogen receptor modulator already you have read that ultimately shows some context dependent activity. That is, in the different tissues, they causes either agonism or antagonism or partial agonism. So accordingly, the adverse effects are lesser and the beneficial actions are the more. The most common two selective estrogen receptor modulator are the tamoxifen and raloxifene. Tamoxifen is used in the breast cancer and raloxifene is used in case of the osteoporosis. So for osteoporosis treatment, ACRM, raloxifene is used. Again, estrogen and androgens, both of these are at the anabolic hormones and these are needed for the bone growth and development. So in the postmenopausal women, when there is very much estrogen deficiency, there may be some consideration of the estrogen replacement therapy also. You have probably read in the sex hormone chapter. So is hormone replacement therapy, HRT, or estrogen replacement therapy, that can also be given when there is severe osteoporosis. But there are some also drawbacks of the giving more estrogen, because when you are giving more estrogen, there may be some chances of the cancer, like there may be some endometrial cancer can happen, there may be some thromboembolism can happen. Again, when there is hypogonadism, that is the androgen hormone is less, so we have to give some androgen hormone replacement to curb the osteoporosis. You have read in the androgen chapter also. So the testosterone injection is there. There are different types of the salts of the testosterone are there, like testosterone enanthate. So you have probably read about this. So these injections can also be given when there is osteoporosis in case of the hypogonadism. So this is all about. So thank you. This is all about the osteoporosis.
Some exam will be taken during MB. There will be 6 different tables, and in 1 or 2 of those tables, one such graph will be given either from Cal or from this pharmacokinetics. This is a log dose response curve. This is log dose, and this is here is a response. Log dose in x-axis, response in y-axis. So log dose response curve of a drug actually, of a drug. Here the main drug we are referring to as agonist, because we are getting a response of this drug. So we are considering this drug as an agonist, because there is a response, it is an agonist. So this is a log dose response curve of an agonist or drug, whatever you say, in absence of an antagonist, the first one. The bold in bold blue, it is in absence of any antagonist, and then gradually in increasing concentration of antagonist. So here there is no antagonist. In this log dose response curve, there is an agonist plus antagonist. And again there is another log dose response curve. Here again you have increased dose of the same antagonist. So this is a pure drug response and drug or agonist response. Here it's a mixed response of an agonist plus an antagonist. So when you are adding an antagonist, there is some change in the response. The curve is changing. And again we are increasing the dose of that antagonist further, the curve is further changing. Now what change can you see from the original curve to these two curves? Can you say? What change can you see? This is the original curve. Starting মানে কোন পয়েন্টে স্টার্টিং? এইখান থেকে স্টার্ট হচ্ছে, তাই তো? একটু যদি এক্সট্রাপোলেট করিস এই জায়গা থেকে স্টার্ট হচ্ছে, তাই তো রেসপন্সটা? আর এর রেসপন্স তার মানে কি চেঞ্জ হচ্ছে এখানে? এই লেভেলটা তো এক, the level from where the response is starting is same. What is changing? Dose. We have to give more dose. Okay, with
increasing doses of the agonist, the curve is moving. With increasing dose of the antagonist, the curve is gradually moving rightwards, parallelly. This is what you have to identify. If the curve is moving rightwards parallelly with dose of antagonist, then what type? Then you will identify that here we are getting competitive antagonism. Okay. Second and third log dose response curves are due to the same agonist in presence of increasing doses of antagonist. The curve shows that the log dose response curves of the agonist shift parallel to the right, without any alteration of the maximal response. This is the most important thing. The maximum response of these three curves are same, only that the dose you have to give is higher. So when you have an antagonist, this is the curve shows phenomenon of competitive antagonism. When you have a competitive antagonist being added to a drug or an agonist, you will get the maximum response. The maximum response will be same, but you have to give higher doses of the agonist. Why so? Because in competitive antagonism, what happens is that the agonist and antagonist, they compete with each other to bind on the same site. Alright, they compete to bind on the same site or the same receptor, same site of the receptor. Okay. Now, when you are increasing when you have added an antagonist, you are getting less response because that antagonist is competing with the agonist. But now, when you are increasing the dose of the agonist is overcoming the antagonist, and that's why you are getting the same maximum response. Alright. Because by increasing the dose of agonist, the effect of antagonist can be counteracted, you are getting the maximum response, same maximum response. So there is a parallel shift. The maximum response is not changing. This is competitive antagonism. So you have to write this down. And examples of competitive antagonism: acetylcholine is the agonist, and atropine for muscarinic receptors of acetylcholine, and D-tubercularine for nicotinic receptor of acetylcholine. Then hexamethonium for nicotinic receptor of acetylcholine. H1 and H2 blockers for histamine. Histamine is agonist, H1 and H2 blockers are competitive antagonists. Morphine, naloxone, naltrexone for adrenaline, phentolamine or propranolol. Phentolamine for alpha and propranolol for beta. These are the examples of competitive antagonists. These also you have to remember. In exam, you might be given a broad question. What is drug antagonism? What are the different types of drug antagonism? There you have to write first physical antagonism, chemical antagonism, then you have to come to these competitive antagonists, non-competitive antagonists, reversible, irreversible, various classifications are there. That you study from your theory, and if it comes in the exam you write. But this is the basic thing you have to remember about competitive antagonism. And the definition, it is what is competitive antagonism? A type of antagonism where two drugs compete for the same receptor site, and by increasing the concentration of the one, the effect of the other can be overcome. That's why when you are increasing the concentration of the agonist, you are getting the same response. Why there is a parallel shift to the right? Because in presence of antagonist, to get the same height of response caused by agonist, the dose of the agonist has to be increased. That's what we discussed. Alright. This is about competitive antagonism. Now look at this curve. There is a bold line. This bold line indicates response of an agonist in absence of an antagonist. Like the earlier, the bold line indicated response of agonist in absence of antagonist. Here also, response of agonist in absence of antagonist. The bold blue line. Now the other lines, they are gradually curves that we are getting by adding antagonist. Apart from the agonist, now we are getting antagonist and we are increasing the dose gradually. What you can see here, you see the maximum response is coming down. There is no parallel shift and the maximum response is coming down. In non-competitive antagonism, this is what happens. Maximum response does not remain same, it gradually reduces. So this is a log dose response curve, agonist in absence and in presence of increasing concentration of antagonist. First log dose response curve is due to some agonist in the absence of antagonist, as we said. Second, third and fourth are due to same agonist in presence of increasing doses of antagonist. As you are increasing the dose of antagonist, the curve is gradually going down. The maximum response from here has come down to here. The tracing shows that the log dose response curves of agonist become non-parallel and shift towards the right with diminution of response. The response is gradually coming down. এখানে ছিল, তারপরে এখানে এলো, then it comes down to here, then it comes down to here. So maximum response is not achieved. Maximum response is not achieved. This is non-competitive antagonism. Very simple. Actually, there are various classifications, sub-classifications. There are some types of competitive antagonism that looks very much like non-competitive. But for practical examination purpose, you need not go into so much of details unless you are specifically asked during Viva. Okay? And very unlikely in too much details you will be asked to write down in practical. Practical maximum types of antagonism with examples that you might be asked. Okay? And if that is asked, competitive, non-competitive, if you say with example, it will be okay. But to get good marks, you have to also give the subtypes. Competitive, reversible, then non-competitive, there is also three types. This is given in Sharma. You have Sharma, all of you? In Sharma, Sharma theory boi ache to? KDT te khub bhalo nei eta. Shanbage অত ভালো করে আছে এটা? এই কম্পিটিটিভ নন কম্পিটিটিভ অ্যান্টাগনিজমের কনসেপ্টটা সবচেয়ে ভালো বুঝিয়ে শর্মার বইটায় আছে, ওটা একটু নিয়ে নিস তোরা, কোথাও থেকে জেরক্স করে নিয়ে নিস ওই জায়গাটুকু 5-6 পাতা, ঠিক আছে? প্র্যাকটিক্যালি এইটুকু লিখলে হবে। যেরকম এই যে এক্সাম্পলটা নন কম্পিটিটিভ অ্যান্টাগনিজম এক্সাম্পল, বেশিরভাগ বইয়ে ভুলভাল আছে, ঠিক আছে? এইটা একটা এক্সাম্পল, বেনজোডায়াজেপিন এন্ড ফ্লুমাজেনিল, এটা একটা এক্সাম্পল, এটা পরীক্ষায় তোরা লিখবি নন কম্পিটিটিভ। কিন্তু ইস্যুটা হচ্ছে যে অনেক বইয়ে ভুলভাল আছে, যেগুলো নন কম্পিটিটিভ অ্যান্টাগনিজমের এক্সাম্পল দেওয়া আছে ওগুলো অ্যাকচুয়ালি কম্পিটিটিভ ইররিভার্সিবল টাইপ, সেগুলো নন কম্পিটিটিভ বলে দেওয়া আছে। শর্মার এক্সাম্পল ফলো করবি আর শর্মা থেকে কনসেপ্টটা প্রপারলি ফলো করবি, ঠিক আছে? আর এই কার্ভগুলো এক্সামিনেশন পারপাসে। Now, these are plasma concentration time curves. মানে in x-axis you are plotting time and in y-axis you are plotting the concentration. তার মানে what is happening here? You have given a drug to a patient. You have given a drug to a patient. Now you are drawing blood sample from that patient. You have given a drug to a patient. You are drawing blood sample from that patient. And you are checking the concentration of the drug in the blood of the patient. ঠিক আছে? তার মানে after giving drug to a patient, what is the concentration of the drug in patient's blood? That you are checking and you are plotting in x-axis and y-axis. In x-axis you are plotting the time from where you have given the drug. This is the time 0, that is when you give the drug, exactly when you are giving the drug. And in y-axis you are getting the corresponding concentrations. ঠিক আছে? x-axis and y-axis. So এখানে this is the time since you have given the drug to the patient, and this is the corresponding concentration. This is the corresponding concentration of the drug in the blood of the patient or plasma of the patient. So this is called the concentration time curve. Now see in this one, this curve A, where do you see? This is the concentration arm. Where do you see the maximum concentration of the drug? সবাই বল, পেছন থেকে বল, ম্যাক্সিমাম কনসেন্ট্রেশন কোথায় পাচ্ছিস? হ্যাঁ, লাস্টে বল, তুই বল, একদম লাস্টে বসে উঠে একটু বল ভালো করে। এই কার্ভে where is the maximum concentration? এসে দেখি যা, আয় চলে এখানে। আঙুল দিয়ে দেখি যা ওখানে, উঠে ওঠ ওখানে। এই কার্ভে এই কার্ভটায়, no, not this one, this curve, where is the maximum concentration? Okay, ja, thank you. So in this curve you see the maximum concentration is here, and what is the time when this maximum concentration is achieved? 0. So in this curve, when you give the drug, almost at that time you get the maximum concentration. At time 0 you get the maximum concentration. ঠিক আছে? In plasma. Now as time progresses, the concentration gradually comes down due to metabolism and other issues. ঠিক আছে? Concentration gradually comes down. This typically happens when by which route, when you have given the drug, this will happen. ওষুধ দিলি আর ওষুধ প্লাজমায় চলে গেল, highest amount. IV, do all of you agree? IV, parenteral, enteral নয়, parenteral. Parenterale কি কি পড়ে? Subcutaneous, intramuscular আর intraosseous, intradermal. তো তোদের মনে হয় এটা IM হতে পারে? Do you think this can be IM or SC or intradermal? Because at point 0 you are getting maximum concentration, the only option is IV. নইলে সঙ্গে সঙ্গে কি করে যাবে? মাসলে দিলেও it takes some time to absorb from muscle. Subcutaneous দিলে it takes some time to absorb from subcutaneous tissue. Even for intradermal from skin, gradually it will go into blood. So it takes some time. Orally maximum time লাগে, more or less usually. Oral route দিলে blood এ যেতে maximum time লাগে compared to other parenteral routes. But among all parenteral routes, fastest is IV. So practically at point 0 you get the maximum concentration. That is only possible in IV. So from this curve you are getting the idea that this drug has been given IV. So these are concentration time curve of a drug given IV. Now what are the informations you are getting from this curve? One is the maximum concentration that is achieved, that is called the Cmax. Here they have written it as C degree P or COP or C0P, whatever. This is actually the concentration, maximum concentration. Then you also get what is called Tmax, that is the time at which the maximum concentration is achieved. The time at which this maximum concentration is achieved is called Tmax. What is the Tmax? 0. This is time, that is immediately when the drug is being administered. So this is typically for an IV drug. Acha, so Tmax, Cmax. What else information you get from this curve? The area under this curve, that is called AUC, area under curve. That gives the idea about to what extent of the drug and at what rate and also to what extent the drug has reached plasma. এই এরিয়াটা it corresponds with the amount or the extent, whatever you say, of the drug that has reached the plasma, which is actually the measure of bioavailability. So you get an idea of Cmax, maximum concentration that the drug can achieve. You get an idea of Tmax, the time at which the maximum concentration can be achieved, and you get the idea of bioavailability, that is the area under the curve. All right. Now you see the last part is given dotted. It is not in bold. The rest of the line is in bold. Last part is in dotted. Why? Any idea? Because when you are giving the injection, at that point immediately we do not draw the blood. Some time elapses. So exactly time 0 যখন just push করা হলো, ঠিক ওই exactly time 0 তেই কিন্তু ব্লাডটা আমরা ড্র করছি না, it's approximate. So this line actually shows that we are getting the extrapolated time. ঠিক আছে, we are extending it and extrapolating it to here. That's why the last part is in dotted. Exactly the patient কে injection দিয়ে তার আরেক হাত থেকে ব্লাড তো টানা হয় না, some time is given. দিলো, ওটা টুর্নিকেট খুললো, পেশেন্টের রিয়াকশন হলো কিনা, we have to wait and see because often these are done in drug trials with new drugs. তারপরে some time elapses, so exactly at time 0 কিন্তু হয় না। হয়তো তুই এই পয়েন্টে নিলি, এই পয়েন্টে নিলি, একটু পরে নিলি, একটু উঠলি, এইখানে পেলি, একটু এগিয়ে গেলি, ম্যাথামেটিক্যাল ক্যালকুলেশন করলি যে আমি at 0 তে এই কনসেন্ট্রেশন এক্সপেক্ট করতে পারি, রাইট? I go back and calculate mathematically or plot in this graph that at point 0 this could have been the highest concentration, right? This is for a drug that is following a unicompartmental model. That means when you are giving a drug in a body, one compartment is the blood vascular compartment. Many drugs mainly remain in this compartment, but drugs that have high bioavailability, they go outside this compartment into various tissues. For those drugs, we say they follow two compartmental model. What happened is that in those cases with drugs that have high volume of distribution, that leaves largely the blood vascular space. Blood vessel থেকে বেরিয়ে টিস্যুতে চলে যায় যে ওষুধগুলো, সেই ওষুধগুলো যখন দেওয়া হয় প্রথমে মেটাবলিজম হয়ে বা এলিমিনেশন হয়ে ব্লাড লেভেল কমার আগে প্লাজমাতে তাড়াতাড়ি ব্লাড লেভেলটা কমে যায় because they leave plasma and go to the tissues. See this curve, it is a straight curve, and here you have a curved line and then a straight line. Can you see? A curved line, curvilinear line and then a straight line. This curvilinear line is because this drug that has been given has high volume of distribution. It follows the two compartmental model. That means a significant portion of the drug after being administered rush out of the blood vascular system. বুঝেছিস? তুই বুঝেছিস? শুভস্নাত বুঝেছিস তো? কি বুঝলি? কি বুঝলি? টু কম্পার্টমেন্টাল মডেল ব্যাপারটা বুঝেছিস? এই দেখ আমার দিকে তাকা। There are some drugs, কিছু ওষুধ আছে যেগুলো খুব হাই ভলিউম অফ ডিস্ট্রিবিউশন, সেগুলোকে যদি দেওয়া হয় তারা সঙ্গে সঙ্গে ব্লাড থেকে পেরিফেরাল টিস্যুতে ছড়িয়ে যায় র্যাপিডলি। তার জন্য কি হয়, তুই ব্লাডে দিলি, একটা কনসেন্ট্রেশন অ্যাচিভ হলো, মেটাবলিজম হয়ে কমার আগেই অনেকটা ওষুধ পেরিফেরাল টিস্যুতে চলে যাচ্ছে, তার জন্য ব্লাড লেভেলে কমে যাচ্ছে, এই হাইয়েস্ট পয়েন্ট থেকে কমে যাচ্ছে। ঠিক আছে? কেন না এটা মেটাবলিজম হয়নি, এ চলে গেছে পেরিফেরাল টিস্যুতে, কারণ এর বায়োঅ্যাভেবিলিটি খুব বেশি। ঠিক আছে? এটা হচ্ছে যারা পেরিফেরাল টিস্যুতে প্রচুর পরিমাণে যায় তাদের জন্য। এদেরকে বলা হয় ড্রাগস দ্যাট ফলো দ্য টু কম্পার্টমেন্টাল মডেল। ঠিক আছে? আউটসাইড ব্লাড ভাস্কুলার সিস্টেম যে কম্পার্টমেন্ট ভাবছি আমি একটা। তাহলে এই যে ফার্স্ট পার্টটা চলে যাচ্ছে, এটাকে বলে ডিস্ট্রিবিউশন ফেজ। ঠিক আছে? এখানে দেখ কার্ভ বি তে আমরা বলা আছে ইনিশিয়াল ফেজ, সেকেন্ড ইনিশিয়াল ফেজ, in this phase distribution of the drug from central compartment to periphery predominates or peripheral tissues. তাহলে এটাকে বলে ডিস্ট্রিবিউশন ফেজ, এটাকে বলে এলিমিনেশন ফেজ। সো ড্রাগস দ্যাট ফলো টু কম্পার্টমেন্টাল মডেল, তাদের কিন্তু একটা প্রথমে কার্ভ থাকে, প্রথমেই স্ট্রেট হয় না, কার্ভ থাকে। দ্যাট কার্ভ ইজ কল্ড দ্য এলিমিনেশন ফেজ, and then you have the curve is called the distribution phase, and then you have straight line, that is the elimination phase. তাহলে if you get a straight one and if you get a curve then a straight one, you can say that this drug has been given IV and it is following the two compartmental model. This drug has been given IV and it is following the one compartmental model. মানে এর ভলিউম অফ ডিস্ট্রিবিউশন কম, এর ভলিউম অফ ডিস্ট্রিবিউশন অনেক বেশি। আচ্ছা, তাহলে আমরা এই কার্ভগুলো থেকে কি কি পাচ্ছি? Cmax, এরও Cmax পাচ্ছি, corresponding Tmax, time to get maximum concentration is Tmax, the maximum concentration achieved is Cmax আমরা পাচ্ছি। আমরা area under the curve পাচ্ছি, bioavailability. From this curve another important information and very important information we get, and in exam you will be asked to calculate also that thing. This is called half life. ঠিক আছে? half life কি? It is the time in which concentration of the drug in plasma gets half. Concentration of the drug in plasma gets half. যে টাইমে, the time required to reduce the concentration of a drug in plasma to half is called the half life. তাহলে এখান থেকে আমরা হাফ লাইফ পাচ্ছি। ক্যান ইউ ক্যালকুলেট হাফ লাইফ? Can you calculate half-life from these two curves? বল, তুই বল। তথাগতর পেছনে তো তথাগত নাম তো সৌভিক, তোর নামটা কি জানো? তোর নাম তথাগত না? তুই তথাগত তো, তাহলে তথাগতর সামনে তোর নাম কি? হ্যাঁ হ্যাঁ, তাই রহমান বুঝলাম, নামটা বুঝতে পারছি না। তাইমুর, তাইমুর, তাইবুর, ইউনিক। আচ্ছা তাইবুর, can you calculate half life from this curve, from these two curves? Can you calculate half life? তমজিৎ, হাফ লাইফ কি করে ক্যালকুলেট করবো এই কার্ভ থেকে? হাফ লাইফ কি করে ক্যালকুলেট করবো এই কার্ভ থেকে? হ্যাঁ, এরিয়া, এরিয়া তো বায়োঅ্যাবিলিটি দিচ্ছে, হাফ লাইফ কি করে বুঝবো? তাহলে কিভাবে বুঝবো বল এই কার্ভ থেকে? এখানে চলে আয়, তথাগত চলে আয়। তাড়াতাড়ি বল, এই কার্ভ থেকে হাফ লাইফ কি করে ক্যালকুলেট করব? এইটা থেকে বল, লেফটটা থেকে। এটা তো একটু কমপ্লিকেটেড, টু কম্পার্টমেন্টাল মডেল, পরীক্ষায় এটা আসার চান্সই বেশি। এইটা দিয়ে বলবে হাফ লাইফ ক্যালকুলেট করো, কি করে করবে?
যদি আমি মানে ইনিশিয়ালি 8 ধরি, কনসেন্ট্রেশন 8, তাহলে এর 50% হচ্ছে 4। আমাকে দেখতে হবে যে 8 থেকে 4 ড্রপ হওয়ার জন্য কতটা টাইম লেগেছে।
কি করে ক্যালকুলেট করবি?
মানে এটা তো স্ট্রেট লাইন, তো এখানে এটা 4 ঘন্টা লেগেছে আর 4 হতে 8 ঘন্টা, তো হাফ লাইফ হচ্ছে 8 - 4
আওয়ার্স। ভেরি গুড। তাহলে ও যেটা বললো এটাই, এখানে একটা কনসেন্ট্রেশন নিবি, তার হাফ কনসেন্ট্রেশন নিবি, এই কনসেন্ট্রেশনটাকে এখানে গিয়ে এখানে নেমে যাবি, ঠিক আছে? যেটা পাবি, 8টা আসছে 4 এ, তাই তো? আর 4টা আসছে 8 এ, তাহলে 4 - 8, হাফ লাইফ হচ্ছে 4 আওয়ার্স, কারণ দিস কনসেন্ট্রেশন হ্যাজ গট হাফ ইন দিস টাইম। এখান থেকেও করতে পারিস, 4 আর 2 একই আসবে, বাট ডোন্ট ডু ফ্রম দ্য ফার্স্ট পার্ট, বিকজ ফার্স্ট পার্টে একটা এক্সট্রাপোলেশন ম্যাথমেটিক্যাল ইস্যু আছে। যে পার্ট, যেটা ডিসক্রিট পার্ট, ক্লিয়ার পার্ট, সেখান থেকে করবি। অলরাইট, থ্যাংক ইউ, যা, ভেরি গুড, ঠিক আছে? তাহলে এইটাই পরীক্ষায় আসবে, এইটাই করতে হবে। এগুলো প্র্যাকটিক্যালে কিন্তু একদম পুরো কোয়েশ্চেন, 6টা কোয়েশ্চেন, 10 মার্কস, একদম এগুলো আসবে। আচ্ছা, এইটা দেখ, দিস ইজ আনাদার প্লাজমা কনসেন্ট্রেশন টাইম কার্ভ। দিস ইজ অফ হুইচ রুট? বল তাড়াতাড়ি বল। ওরাল রুট। দিস ইজ টিপিক্যালি ওরাল রুট। দেখ সবাই, দেখ ওষুধটা দেওয়া হলো at 0.0, কনসেন্ট্রেশন অফ ড্রাগ ইজ 0, ইয়েতে হয়ে যায় হাইয়েস্ট, এখানে দেখ অলমোস্ট 0 বা 0 এর একটু বেশি হবে আর কি। গ্র্যাজুয়ালি ইটস ইনক্রিজিং, গ্র্যাজুয়ালি drug is getting absorbed, it reaches peak and then it is gradually coming down. This is for oral, this can also be for other parenteral routes, IV বাদ দিয়ে, IM, subcut, because সেখানে কি হবে, আরো ফ্ল্যাট হবে, আরো ফ্ল্যাট হবে, সরি আরো শার্প হবে, কারণ অ্যাবজর্পশনটা ফাস্টার হবে, আরো শার্প হবে, বাট ওইভাবে ডিস্টিংগুইশ করাও মুশকিল। ইউ ক্যান হ্যাভ অ্যান ওরাল ড্রাগ that absorbs very fast, almost like a subcut injection, ঠিক আছে, particularly under certain conditions. So basically this can be for a subcut or IM, other parenteral routes other than IV, because there also you have to pass through some phases before you reach the blood. And this is oral, typically oral, but also those type routes of administration this curve is applicable. এগুলো এবার পড়ে নি। Curve A, uniform decline in plasma concentration of the drug with time. This is curve A. Curve A, uniform decline in the plasma concentration with time. Curve B, decline of the plasma concentration in two phases. Initially there is a rapid phase which is the distribution of the drug from central compartment to periphery, মানে blood থেকে peripheral tissues, and a second phase the elimination of the drug predominates, that is metabolism. Curve C, at first there is gradual increase in plasma concentration, this is the phase of absorption, then after reaching the peak concentration there is a uniform decline in the plasma concentration of the drug. What may be, this is a question you will be asked in exam to write down, what may be the routes of administration of drug in these curves? In curve A and B, drug has been administered IV because peak concentration has been achieved at 0 hour. In C, drug has been administered orally because there is a phase of absorption in the initial phase. This is mainly oral, but if you are further asked what other routes is possible, you can say intramuscular, subcutaneous, like that, but this is typically of oral. What purposes do these curves serve? From these curves we get important pharmacokinetic informations that we have already discussed, like Cmax, Tmax, volume of distribution, half-life and bioavailability. তাই তো এগুলো ডিসকাস করলাম তো, পাই তো? বায়োঅ্যাভিলিটি মানে এরিয়া আন্ডার কার্ভ, হাফ-লাইফ তো তথাগত বলে গেল কিভাবে করছি। ভলিউম অফ ডিস্ট্রিবিউশন কি করে ক্যালকুলেট করি? ইফ ইউ নো দ্য ডোজ অফ দ্য ড্রাগ দ্যাট ইজ গিভেন, see there the formula is written here. If you know the dose of the drug that is given, then volume of distribution is the dose of the drug by the maximum concentration of the drug that has been achieved, that is the volume of distribution. So all these vital informations are needed for the dosing pattern. কত ডোজ দেব, কতক্ষণ পরে পরে দেব, that is decided from these informations. ঠিক আছে? So Cmax is defined as the max, Cmax Tmax এর definition আছে, plasma half life এর definition আছে, it is the time in which plasma concentration of drug is reduced to half. নিচটা কেউ দেখতে পাচ্ছিস পেছন থেকে? 6th question দেখতে পাচ্ছিস? হ্যাঁ, তোরা পাচ্ছিস পেছনে 6th question? 5 অবধি দেখছিস তাই তো? 6th questionটা আছে, very important. How many half lives are required for complete elimination or to achieve a steady state concentration in exponential kinetics? That is 4 to 5. Exponential kinetics মানে ফার্স্ট অর্ডার কাইনেটিক্স, এটা ম্যাক্সিমাম ড্রাগ ফলো করে। 4 to 5 হাফ লাইফসে আইদার স্টেডি স্টেট চলে আসে, নয়তো ইট ইজ অলমোস্ট এলিমিনেটেড। ঠিক আছে? কিভাবে হয়? 100 থেকে দেখবি 50, 50 থেকে 25, 25 থেকে 12.5, এরকম করে যত কমতে থাকবি লাস্টে দেখবি সে নেগলিজেবল হয়ে যাচ্ছে 4 to 5 লাইফসে। কার্ভ বি, হাউ ইউ ক্যালকুলেট হাফ লাইফ, এই যে কার্ভ বি তে কিন্তু দুটো হাফ লাইফ থাকবে। If there is an alpha phase and beta phase, you will have 2 half lives, but we are more interested in the beta half life, that is the elimination phase half life. Distribution phase half life thing we are not so important. And as I told you, curve A and C follow one compartment and curve B follows 2 compartmental model. And this example you have to remember, drugs that are following 2 compartmental model, IV diazepam, IV thiopentane, তোদের যদি এই কার্ভটা দিয়ে বলা হয় give examples of 2 drugs that shows this type of a curve, you have to write down IV thiopentane and IV diazepam. How will you calculate half life of any drug from plasma concentration time curve? That তথাগত has shown. Bioavailability definition পরীক্ষায় কিন্তু লাগে, even practically লিখতে দেওয়া হতে পারে। area under the curve এর কনসেপ্ট থেকে যে what is bioavailability, এই ডেফিনেশনটা কিন্তু বলতে হবে। rate of appearance and the fraction দুটোই বলতে হবে। the rate, how do you calculate oral bioavailability? Oral bioavailability হচ্ছে AUC oral, the area under the curve oral by area under the curve IV. If you give a drug IV, the area under the curve that you get, the same drug when you give oral, the area under the curve you get, the fraction that we get is the bioavailability. And here are theoretical discussion, the factors that determine the bioavailability of a drug. এটা তোদের থিওরি ক্লাসে ডিসকাস হয়েছে ডেফিনেটলি। There are some pharmaceutical factors like particle size, physical nature, chemical nature, excipient, disintegration time, dissolution time, এগুলোর উপর ডিপেন্ড করে কি বায়োঅ্যাভিলিটি হবে। Then factors related to absorbing media, motility of the gut, presence of other foods, drugs, pH of the gut, vascularity, area of absorption, pathological condition, all of them affect bioavailability. The age, what is the extent of fast metabolism, and whether any liver disorders, kidney disorders, etc. are present, and some genetic factors, they also determine bioavailability. কিছু genetic changes থাকে বা স্পেশালিটি থাকে যার জন্য বায়োঅ্যাভাইলেবিলিটি অল্টার হয়ে যায়, ঠিক আছে? যেরকম তোর ফাস্ট অ্যাসিটাইলেটার্স এন্ড স্লো অ্যাসিটাইলেটার্স, আইসোনিয়াজিক বলে একটা অ্যান্টি টিউবারকুলোসিস ড্রাগ আছে, ইট ইজ মেটাবলাইজড বাই অ্যাসিটাইলেশন, ঠিক আছে? নাও ইন সাম races like Americans, Israelis, acetylation occurs fast, and in some races like Japanese, Chinese, acetylation occurs slow. সেই অনুযায়ী কিন্তু বায়োঅ্যাভাইলেবিলিটি ভ্যারি করে যায়, the amount of drug that is remaining at the site of action, ঠিক আছে?
What is the first? This is a soluble antigen. The antigen is soluble. Now example, VDRL and RPR, flocculation test, these are the common precipitation tests. So VDRL and RPR. Now example of agglutination test. There are two types of agglutination. One is side agglutination and tube agglutination. That is differentiated by the method of testing. What else? There is one passive agglutination. What is example of passive agglutination? Most of the tests we do in the lab are example of passive agglutination. Because when ELISA is a different method. Passive agglutination, passive agglutination. What are the example of passive agglutination or agglutination? Agglutination, what is the main difference? The antigen is particulate or insoluble antigen. So it is particulate antigen. Example, all latex agglutination tests are like ASO titer, RA factor and CRP, or cryptococcal antigen test. Here the antigen is originally soluble, but it's made particulate by using the latex particle. So these are mainly latex agglutination tests. So these are the two common tests, agglutination and precipitation. What other the two types of conventional serological tests? One is complement fixation test, rarely used nowadays, and another is neutralization test. What is neutralization? What is an example of either hemagglutination test or hemagglutination inhibition test are used for as complement fixation tests. Next is the neutralization test. What are the examples? Either toxin neutralization test or it is viral neutralization test. So these are the four conventional method of serological tests commonly used in lab. But nowadays newer methods have come. What are the newer methods? Here we bit complicated, but the detector molecule is there and there are some antibody. Detector antibody, detector substrate. What is the role of detector antibody? What is the role of detector substrate? Detector substrate produce the color so that you can see either spectroscopically or fluorometrically, you can see the color is developed, that means test is positive. So substrate and enzyme substrate, another enzyme. What are the common enzymes usually used in ELISA? I will come later. So what are the molecule used? One is ELISA. What is the full form? Enzyme linked immunosorbent assay. Why it is called immune sorbent? The polystyrene plate I showed last day, the antigen antibody are adsorbed on the polystyrene, that is a solid phase assay. Is it called a solid phase assay? So enzyme, substrate and chromogen complex. So what enzyme commonly used? Enzyme commonly used are either alkaline phosphatase or horseradish peroxidase. These are the two common enzymes used. Now color change is detected by spectrophotometry. What are the others? Enzyme linked fluorescent assay, immunofluorescent assay, radioimmunoassay and chemiluminescence assay and immunohistochemistry. Immunohistochemistry mostly done in pathology for detecting the marker. Cancer marker are commonly detected by immunohistochemistry. That will not be taught very in details in microbiology, but you should know them. These are the common immunoassays. Most common you should know ELISA and chemiluminescence immunoassay. What is the difference between chemiluminescence and ELISA? ELISA is mostly manual. You have to add the reagent, enzyme, substrate in every step and incubate. But in CLIA, full thing is automatic. Previously it was told the sensitivity is almost same, but now with advent of newer tests, CLIA is said to be more sensitive. And manual work will be less. Put the sample in the machine and it will give the result. So there is another advantage is what? Manual error is minimized. There is no manual error. Because ELISA you need to do pipetting. 50 microliter, 10 microliter substrate or enzyme or the sample, that is depend on the manual of the laboratory technologies. But CLIA is fully automatic. Chemiluminescence immunoassay. Western blot. Western blot, what is done? There is the antigen is blotted in a gel and then the corresponding antibody, whether present in not, is detected. Western blot used in which disease? Western blot. What is the confirmatory test? It is HIV. Yesterday, last class, HIV was shown. They either rapid test, lateral flow, flow through ELISA, but confirmatory test for HIV is Western blot. But according to the NACO, whether you were told about NACO protocol yesterday, last week. So there, if he is a patient, I won't go to the details, the 1, 2A, 2B and 3. So that confirmatory test of HIV is Western blot. And rapid test, immunochromatography and flow through assay. Immunochromatography means lateral flow, or flow through is sample goes from top to bottom. Now ELISA, the main that detects either antigen or antibody in the specimen by using enzyme substrate chromogen complex. Why it is immune sorbent? Absorbing material polystyrene or polyvinyl that specifically absorbs the antigen or antibody. Enzyme is used to label one of the component of immunoassay. So enzyme is used for labeling. Substrate chromogen system is added to the final step. Enzyme substrate reaction in turn activates the chromosome to produce a color. So simple, there are different types of ELISA. Main principle is whether you try to detect antigen or antibody, if you are trying to detect some antigen. So we are trying to detect the antigen. So antibody must be there. Absorbed in commercial plate, antibody will be there. Now if the sample is added, antigen is there. Then antigen antibody complex will be there. Remember, we are trying to detect the antigen. Like example, NS1 antigen in dengue. Most of the case we try to detect antibody. Dengue in first 5 days, we detect NS1 antigen. Then what to do? The antibody is coated. Antibody is there in the commercial plate. Now the sample is added. If antigen is there, it will react with antibody, will form antigen-antibody complex. In next, antigen-antibody complex is there. Now we will do some antibody plus enzyme. Antibody will be, we will give some antibody reagent. What we will next give? This specific to that antigen. So then antigen, antibody and enzyme will be given. And next step, after this, so this is the antibody here, their antigen. Now we are giving the second antibody with enzyme. Then we use the substrate chromogen complex. And on incubation, color will develop. So when you try to detect antigen, the polystyrene plates are coated with antibody. When you are trying to detect antibody, the antigen to be coated. This is for direct ELISA. But direct ELISA is usually not done. So this is the first. Color change is detected by spectrophotometry in ELISA reader. When you have time, go and see the ELISA reader. Don't come all at the same time, but you can see ELISA reader and ELISA washer, both are there in the department. You come and see how it looks like. So intensity of the color is directly proportional. So it is basically a quantitative type of test. Though sometimes it is qualitative, yes or no, but it is a quantitative. So intensity of the color is directly proportional to the amount of antigen or antibody present in the serum. Antigen-antibody complex, enzyme and substrate activates the chromosome and color change occurs. So this is a picture of ELISA. This is an ELISA reader and that is an ELISA washer. Because washing is needed in every step to remove excess antigen-antibody which is not used in the reaction. So washing is required in every step, and here is the final step for reading the color of the chromosome. Usually performed on a microtiter plate containing 96 well. Either polystyrene, commonly it is a polystyrene, it may be a polycarbonate or polyvinyl. ELISA kits are usually commercially available. All the necessary reagents will be there in the kit. A series of steps, each step a reagent is added, then incubated, followed by the washing of the well. Now what are the types of ELISA? This is asked, what are the types of ELISA, and any of them can come as short note. Most commonly this come IgM antibody capture ELISA. Where it is commonly done, IgM antibody capture ELISA. Why specifically only IgM? This ELISA was named for only IgM capture ELISA. Okay, direct ELISA, what I have shown on the board is an example of direct ELISA. Next, indirect ELISA, sandwich ELISA, IgM antibody capture ELISA, MAC. What is the full form of MAC? IgM antibody capture, good. IgM antibody capture ELISA, competitive ELISA and ELISpot test. Direct, used for detection of antigen in the test serum. Primary antibody is labeled with the enzyme. So this is an example of direct ELISA. Step 1. Walls of the microtubulated plate are empty, not pre-coated. Test serum containing antigen is added, and then after washing, enzyme level antibody are added. And then after washing, a substrate chromogen system. This is very simple. We are not adding anything. Antigen, antibody, nothing we are giving in the well. we are directly putting the serum first, serum sample, then we are putting the specific, we are detecting antigen only, direct. Then we are giving the antibody coated with enzyme. Which enzyme? Either horseradish peroxidase or alkaline phosphatase. Then we are using a substrate chromogen for development of color. Well, antigen, primary antibody enzyme, substrate chromogen and color change occurs. This is a simple direct ELISA. Differs from direct ELISA, the secondary antibody is labeled with enzyme. Now indirect. What is indirect? Directly not detected. The solid phase of the wells or plates are pre-coated with the antigen. Antigen, here we are detecting antibody. ELISA is a bit difficult, but try to understand. If you don't understand any part, please tell me. যেখানে confusion হচ্ছে সেখানে বলো, কারণ ELISA is bit difficult. Now the solid phase, এখানে what we are detecting, direct ELISA, what we were detecting? In direct ELISA, we were detecting only antigen. In indirect ELISA, we are detecting antibody. So direct ELISA, what we detect? Antigen only. Indirect ELISA, we are detecting antibody. So here, wells are coated with the antigen and test serum containing primary antibody. What is primary antibody? What is secondary antibody? What do you have understand about the primary antibody and secondary antibody in ELISA? Primary antibody and secondary antibody? Primary antibody is the antibody present in the serum of the patient, not for the detection. The secondary antibody is used for the detection with enzyme. The secondary antibody is what we detect for detector antibody, and that is linked with, first linked with the enzyme. So first primary antibody is the antibody that is present in the patient's serum. Then test serum containing the primary antibody is added to the wells and antibody gets attached to the antigen. After washing, the enzyme labeled second antibody is added, and after washing, a substrate chromogen system is added. This is indirect ELISA. Wells with antigen picture, primary antibody, secondary antibody with enzyme, then substrate chromogen is added. Sandwich ELISA. What we detect sandwich ELISA? What is the commonest example of sandwich ELISA? Commonly done in lab, sandwich ELISA, that means antigen is sandwiched between two antibodies. So what we detect antigen. Commonest test, what the commercial NS1 antigen test is a sandwich ELISA. Commercial NS1 antigen test is usually a sandwich ELISA. So detects the antigen, so named because the antigen gets sandwiched between a capture antibody and a detector antibody. So capture antibody will be there coated in the well, and next we add the detector antibodies. Same thing, microreactor well is pre-coated with the capture antibody targeted against the test antigen. Which antibody is this? A specific antibody? This initial antibody is, it is the non-specific antibody. It is not specific to antigen. Here the primary antibody or the pre-coated antibody is monoclonal antibody raised in rabbit that is targeted against the test antigen. The test serum is added, well, antigen get attached to the capture antibody, and after washing, enzyme level primary detector antibody specific for antigen is added. Here is, and after washing, so what is done initially? We are using antibody against the antigen that is pre-coated in the well, that is also specific to antigen. Next, after the antibody is then serum containing antigen serum is added. If the serum is added, that antigen will react with the antibody, specific antibody. It will form an antigen-antibody complex. Then we against another specific to that antigen, another antibody, and that is coated with the enzyme. That means this is two antibody. We are detecting antigen. Here is we are coating with antibody. So antibody is there. So this is primary antibody. Next we adding sample. Sample contains antigen. So antigen go and will react with antibody. After that we are detecting this by another antibody. Attached to the capture antibody, this is capture antibody. This is called capture antibody initially coated. This is primary antibody. So this antigen is sandwiched between two antibody. This antigen is sandwiched between two antibody. One is the primary antibody, that is the capture antibody, and next the detector antibody. After washing, the substrate chromogen is added. Any query about the sandwich, ELISA? So antigen is being sandwiched between two antibody. One is capture antibody, one is detector antibody. That is sandwich, ELISA. Commonest example is NS1 antigen testing. IgM antibody capture, ELISA. It was initially started for dengue IgM. So sometime it is asked if it is IgM antibody, MAC ELISA is given in the short note. First question, why we have started MAC ELISA? Why we have started MAC ELISA? Can anybody? Why we have started MAC ELISA? We could have done it by the indirect ELISA also. Why we don't use indirect ELISA, but we have started MAC ELISA? Which will be more in number, IgM or IgG? IgG will be more, they are smaller molecule and they will be more numerous than IgG. So usually IgG is smaller in size, IgM usually IgG is smaller. So they will, if we coat it with antigen, then this IgG antibody will go. And indirect ELISA, then the detected antibody will be against IgM. But here we have what is attached? It attaches IgG. So there will be false negative. So as IgG is smaller, they will attach with the antigen and lead to the false negative test. Second part, this is the first cause. Why MAC ELISA is used? IgG is smaller, they will go and first attach with the antigen. Second part, some patient may have rheumatoid arthritis, that is RA factor positive. What is the antibody found in rheumatoid factor? Which type of antibody is rheumatoid factor antibody? It is IgM, rheumatoid factor or rheumatoid factor antibody is IgM against IgG. So if a patient is rheumatoid arthritis, patient having rheumatoid arthritis, what will happen? This IgM may go and attach with the antigen coated. They are having IgM against that antigen, any anti-IgM. So they will attach with that antigen and that will give a false positive reaction. So one is There may be false negative reaction due to as IgG is smaller and IgM is larger molecule. So IgG will go first and attach with the antigen, that will give a false negative reaction. And if a person is already suffering from rheumatoid arthritis, then the IgM, the rheumatoid factor, which is an IgM against IgG, that IgM will go and attach with the antigen, giving a false positive reaction. That's why the MAC ELISA was evolved. লিখেছো IgG হলে ওটা false negative হবে, যদি IgG more small হলে, আর if patient is already having rheumatoid factor, then there may be false positive result. So enzymatically amplified sandwich type of immune ELISA commonly used for dengue, Japanese encephalitis, Kraft typhus, leptospirosis and toxoplasmosis. Based on the primarily capturing primary IgM antibody. So now in this ELISA, what will be there in the plate? In plate, what will be there? This is 2 plate example. What will be there in the polystyrene or well? What will be there? We are not coating it with antigen. We will coat with anti-IgM antibody. Only anti-IgM antibody. So if anti-IgM antibody is there, they will attach with this. This is attached. So only anti-IgM, so initially the polystyrene well will be coated with anti-IgM antibody. Enzyme level secondary antibody specific for the antigen is added, followed by addition of substrate and chromosome system. Use of avidin biotin system helps in amplifying the signal between the enzyme antibody complex that increase the sensitivity. How we increase the sensitivity? Avidin biotin system is added along with. Now here the step. Wells coated with capture anti-IgM antibody, then serum containing IgM antibody. There is reaction between anti-IgM antibody and the dengue IgM antibody. Then what is done? After that what we add? We add the specific antigen. Then we add the antigen. So wells coated with capture anti-IgM antibody. IgM antibody will be there in the serum. Then we are adding the recombinant antigen. After that, so antigen-antibody complex will be there now. That antibody we will detect by secondary antibody biotin avidin enzyme complex. So avidin biotin in added extra, then indirect ELISA. That will amplify the antigen-antibody complex color. Then substrate chromosome and color. Competitive ELISA. What is? Have you understood the MAC ELISA? Any question regarding MAC ELISA? IgM antibody capture ELISA. What we are putting in the well is anti-IgM antibody. Then serum is added. So IgM is attached with that anti-IgM antibody. After that we are adding the antigen. Then antigen-antibody reaction will occur with that IgM antibody. After that we are adding secondary antibody with avidin biotin enzyme complex. If you even don't remember, at least remember this is done because 2 reasons I have already mentioned. One is IgG is smaller molecules and patient having rheumatoid arthritis. These are the 2 causes for developing MAC ELISA. Now competitive ELISA. antigen in the test serum competes with another antigen of the same type coated on the well to bind to the primary antibody. First primary antibody is first incubated in a solution with serum sample containing the test antigen. So what is initially done? This is competitive ELISA. Primary antibody is there. We are adding the serum. If specific antigen is there, then antigen-antibody reaction will occur. Primary antibody first incubated. Next, antigen-antibody mixture is then added to the microtiter well, pre-coated with same type of antigen. So what will happen? If we add same type of antigen, what will be the result? If the test is positive, whether the color will develop or not. Patient serum already containing the specific antigen. So we are first incubating with primary antibody. If antigen-antibody reaction already occurs, there will be no IgM or no antibody will be free to catch hold of this antigen. So if color does not develop, test become positive. It is an indirect method of detecting. So antigen mixture is then added with the same type of antigen. Free antibodies bind to the antigen, and more the test antigen present in the sample, lesser free antibody. Free antibody will not be there. If the serum already contains the specific antigen, antigen-antibody reaction would have occurred. So after washing, a substrate chromogen system is added and color is developed. Intensity of the color is inversely proportional to the amount of antigen. Initially in all previous tests, what we were seeing, the more the color developed, more the antigen or antibody. Here it is opposite. Less the color, that means more antigen were there in the patient serum. That is the main principle of competitive ELISA. ELISpot test. It is a modification of ELISA that allows the quantitative detection of the cells producing antibody, plasma cells or cytokines. Currently used for IGRA, interferon gamma release assay. What is the role of IGRA? IGRA, where we have read already, interferon in latent tuberculosis. What is the difference between the IGRA and Mantoux test? IGRA and Mantoux test. What should we prefer? Whether we should go for IGRA or we go for Mantoux test? And what are the implications for Mantoux test and IGRA? Tuberculin test, what it detects? Whether it has an exposure to tubercle bacilli. What IGRA detects? Interferon gamma release assay also detects the exposure to tuberculosis or latent tuberculosis. But what is the difference? What is the clinical interference? If it is Mantoux positive and if it is IGRA positive. If you have taken BCG vaccination, what would be the result of both the tests, IGRA and Mantoux? Both positive. Mantoux will be positive, but IGRA will not be positive. So that is a more specific test. IGRA is a more specific test. So why we are continuing with Mantoux test? We are resource poor country. The cost is high for IGRA, cost is much less in case of Mantoux test, but IGRA is now coming up in USA. Mantoux has been obsolete. They only do the interferon gamma release assay. That gives a, what is clinical interference is this patient is already exposed to tubercle bacilli or patient may having latent tuberculosis. Now, who secrete interferon gamma? Which cell? It is a T cell or B cell which secrete the gamma interferon. It is T cell. What is avidity, Eliza? Useful differentiating recent from past infection. Recent and past infections are differentiated by the presence of IgM and IgG antibody respectively. In situation where both the antibodies are present, IgG avidity test is useful to differentiate recent from past infection. Avidity means how firmly an antibody binds with its antigen. Reflects the maturity of the antibody, which usually increases with time. So, detection of low avidity IgG indicates recent infection. In which disease commonly we do the avidity test? One example where we go for IgG avidity test. It can come in your MCQ also. One example is toxoplasma. Rubella, cytomegalovirus, varicella zoster virus and toxoplasma. In toxoplasma, we usually do it, and in case of pregnancy. Pregnancy patient having suspected toxoplasma, we do IgG avidity test. So this will prove whether the patient was previously infected or infected during pregnancy. What is the advantage of ELISA? Then rapid test. First advantage, what is the advantage of ELISA over rapid test? Like latest agglutination test or other test, it is more specific and more sensitive. The lateral chromatographic test for hepatitis B and C you have seen, they are more sensitive, but ELISA is more specific. ELISA is more specific, so you have to confirm. If it is come positive in a rapid test, you have to do a confirmatory test with ELISA. As in HIV, you have for an asymptomatic patient. Last week HIV class was there. If a patient is asymptomatic, no AIDS related symptom is there, how many tests you should do to call it an HIV positive? 3. It is 3A, protocol 3A. And if the patient having HIV related like candidal esophagitis or HIV related symptoms, then how many tests? Patient having some AIDS related symptom, how many tests to be done? 2 tests. Okay. That is 2B, protocol 2B. And protocol 1 for what? NACO guideline. 1 is used for any blood transfusion or any transplant. Used for, because that one test, if it comes positive, whether it is a rapid ELISA, that this sample is discarded. ELISA has a high sensitivity. It is commonly used for screening tests at blood bank. In small laboratory having less sample load, ELISA is less preferred than rapid test. Flow cytometry. You need to know this term where it is most commonly used, flow cytometry. Flow cytometry, it is commonly used in what total WBC count, that is total is detected. In flow cytometry, every single cell is detected by corresponding antibody. So what is the most common clinical use of flow cytometry? Either you are separating component separation, or commonly in which disease we do flow cytometry regularly to monitor the treatment. HIV, what we check? One of the monitoring factor is CD4 level. CD4 level, so here flow cytometry is used. to detect. One is anti-CD4 and one is anti-CD8. Two monoclonal antibody are there in the kit in flow cytometry where we can detect the CD4 level and its level in comparison to other CD8 cell. So flow cytometry is a laser based technique that quantitatively analyzes and separates the cell. So when it separates the cell, that is used for a single cell only. Every single cell goes through the flow and used to analyze multiple parameters like cell counting, cell sorting, analysis of size, granularity, DNA or RNA content. Anything can be detected. CD4 T cell count is a common detection of leukocyte with specific marker for the diagnosis of different lymphoma. Now chemiluminescence immunoassay. What is the principle of CLIA? Emission of light, that is luminescence as a result of chemical reaction. The principle is similar to ELISA, that this is an antigen-antibody reaction. However, the chromogenic substance is replaced by chemiluminescence component. A chemiluminescent compound like luminol or actinium esters are used that generate light during a chemical reaction. Light can be detected by photomultiplier. So, chemiluminescence, what is the difference with ELISA? Where enzyme and chromogen are used, here we use the chemiluminescent compound like luminol or actinium ester that generate light, and that light is detected by photomultiplier. This is a picture of CLIA. What is the advantage of CLIA? Now it is being told that it is 10 times more sensitive than ELISA and further modified by using an enhancer that potentiates the chemical reaction. Most samples have no background signal. Measurement of chemiluminescence is not a ratio unlike the measurement of fluorescence or color. So these are the advantages of CLIA. What is the disadvantage? Why every lab doesn't have a CLIA? Or even if you have CLIA, you have to keep an ELISA machine also in the lab. That is the first drawback. All the microbiology tests are not available in CLIA. So, not all the chemicals available for detection of antigen antibody like hepatitis virus, HIV, TORCH and biomarker like ProCal. Flow cytometry already I have covered. Any question regarding ELISA?
Interpretation of serological tests. What are the serological tests that you have learned about till today? Okay. Okay. Those are the recent tests. What are the old tests that can be done? Precipitation test, agglutination test, and neutralization test. Anything else? Any other test? Complement fixation test. Anything else? Have you understood what are the principles behind this test? See, simple enough, all these tests are reaction between antigen and antibody. So, if we are looking for an antigen, we need to react with an antibody. Similarly, if we are looking for an antibody, we need to react with an antigen or an antibody directed towards that specific antibody. Okay. Now, so What is precipitation reaction? আরে বলো, তোমরা কিছু বলো, প্র্যাকটিক্যাল ক্লাসে এসছো, মুখ বুঝে বসে থাকলে হবে? 2 সপ্তাহ ধরে পড়ানো হচ্ছে। What is precipitation? What is agglutination? That is the basic first question জিজ্ঞেস করা হবে। তাহলে ডিফারেন্সটা কি হয়? ওকে, সলিউবল, আফটার রিয়াকশন ইট বিকামস ইনসলিউবল। আর আরেকটা হচ্ছে ইনসলিউবল হয় না। যদি ইনসলিউবল না হয় তাহলে কি অ্যান্টিজেন অ্যান্টিবডি রিয়াকশন আমরা দেখতে পাবো? উইল ইট বি অবজারভেবল? অবভিয়াসলি নট। টু সার্কামভেন্ট দ্যাট, what is done is known as agglutination by adding some other material to the react. অ্যান্টিজেন অ্যান্টিবডির মধ্যে যে কোনো একটা অ্যাডিশনাল মেটেরিয়াল দেওয়া হয় to render it insoluble. Okay, most commonly used particle is known as latex particle, hence the test is known as latex agglutination. খুব সিম্পল, পার্টিকেলের সাইজ বড় হয়ে গেলে রিয়াকশনটা আমরা পারসিভ করতে পারবো, so we can do the test in the laboratory. Okay, there are various other methods. For example, charcoal can also be used. Okay, today we will see 3 examples of latex agglutination test. Okay, the first is this. Principle খুব সোজা, agglutination মানে ক্লাম্প তৈরি হবে, যেহেতু latex white particle, so you can see a white suspension. When I rock the slide, you can appreciate there are granules at the, এটা যখন ঘোরাচ্ছি, ড্রপলেটটা যখন ঘুরছে, at the tail end or the tail of the droplet you can appreciate granules. হাত দিও না, দেখো, দেখতে পাচ্ছ? দিস ইজ পজিটিভ, দিস ইজ নেগেটিভ, নেগেটিভটা নেই, ঠিক আছে? পিছনে যে এগিয়ে এসে দেখেন, দেখতে পাচ্ছ? এটা অল্প বিস্তর মনে হচ্ছে ছানা ছানা কাটার মতো, দেখতে পেয়েছ? ঠিক আছে? So the particles in this is latex particle. Okay, বোঝা যাচ্ছে? এটা all 3 tests have the same principle, but commonly আমরা এই 3টে জিনিস at least তোমাদের আন্ডারগ্রাজুয়েট লেভেলে এই 3টে টেস্ট করে থাকি. So I will be discussing very little bit about these 3 tests. The first test is known as, কি লেখা আছে? ASO. What does ASO stand for? Very good. What is anti-streptolysin? কি? Okay, virulence factor, it's a protein, streptolysin O. Streptolysin has 2 parts, one is the stable and the labile. Okay, so it's oxygen labile. Now this is a toxin which is also a protein. So what happens is, when a person gets infected with streptococcus, this protein is exposed from the organism to the human body. Hence the human body will form an antibody against this. Understood? So this antibody will rise after the infection. So this antibody test is called as anti-streptolysin O. Understood? Now how we do this test? Remember, we are looking for an antibody that is formed within the human body. So we need an antigen. What will be this antigen? Commonly used is a goat antibody. So if we inject the human antibody into a goat, what will happen? The human antibody will act as an antigen and the goat will start producing antibody against it. Now this antibody will specifically react with the human antibody. Now suppose if we had previously injected the goat with anti-streptolysin or antibody, what will happen? An antibody to anti-streptolysin antibody will form. বোঝা গেছে? Now we tag this goat antibody with latex particle. Understood? Now suppose this person comes, he says, I had a sore throat a week back. Now I take his blood, take the serum, then react with this antigen. What will happen? If he had developed the antibody, that antibody will be present in his serum, it will react and will give clots. If that reaction comes positive, we say he is having anti-streptolysin antibody, that is ASO titer is raised. Understood? Now what will be the normal level of ASO titer? Below 200. See, it's generally we for at least on your part it's below 200, but it's not a static. It depends on the age of the child. For example, if the child is not going to school, the level will be slightly higher. When it goes to school, slightly lower. So it varies. On an average, for your curriculum, you should understand any ASO titer less than 200 is not indicative of recent infection. Please remember this part, recent infection. That means what happens if you get a streptococcal infection, the titers will rise maximally after the end of the first week. Then it will slowly come down. By 4 to 6 weeks, it will go back again to the original or below the detection level. Understood? Then what is the use of this test? You are going to the pediatrics clinics? Not rheumatic fever. See, children will have, most of the time, if you go to the pediatric clinic, most of the mothers will come and say, my child is having fever. There could be many causes of fever. Okay? And one of the very common causes of fever, especially in school going children, is a streptococcal infection. Okay? Now, what is the problem with streptococcal infection? Now, what is the consequences of streptococcal infection? Exactly. The post-streptococcal sequelae, we are not very much concerned about the sore throat. It could be viral, it could be other bacterial. So, we need to ascertain whether actually it's a streptococcal infection or not. What are the complications of a streptococcal infection? Exactly, you have to consider that. And furthermore, not every time, even if you recommend a throat culture, not every time the throat culture will come positive. Suppose you have observed the child in your OPD and you have advised for the throat culture. Okay, the culture will be sent next day. If the child gets more febrile, will you withhold the antibiotics? Obviously not. Ideally, it is said that you should take the culture and then start the antibiotic. But practically, it's not always possible. Now, if the child has been given the antibiotic, what will happen? The culture will come negative. If the culture comes negative, then how can you prove that it's a streptococcal infection? By immunological method. Understood? So the child have got better. After 1 week, you test for the ASO titer. If the titers are raised, that means that infection was streptococcal. Understood? This is a retrospective diagnosis. Remember, this will not help. Another important part where it helps is, similarly, a child has fever, about 3 to 5 days have gone by, and you have failed to diagnose. Do an ASO titer. By that time, a rising ASO titer will also indicate a streptococcal infection. Understood? Okay. This is the first part. Next is, we'll talk about CRP. What is CRP? What is C reactive protein? Right, it's an acute phase protein. It is secreted by, right, hepatocytes. So why does liver releases these things? What do you mean by acute phase reactants? Acute phase reactants means when the body is undergoing any sort of inflammation, maybe infective, maybe non-infective, it releases certain proteins. They act as a marker. One of those markers is C-reactive protein. How we detect this one? It's very simple. We need to take an antibody, that is this antibody against C-reactive protein. Latex particle is attached with. Latex agglutination test is done, and if it comes positive, that is, if it is more than What? You have been told, na? More than 10. There are certain variations, but at least more than 10 is conclusive. Some kids will say about 6. If in doubt, always look at the literature of the kit that is being done. Okay, because that has been standardized and tested for. For example, in this kit, I think, yeah. This kit is for 0.6 milligram per dl. So anything above 0.6, this test will come positive. Okay. Similar to ASO titers, CRP also is indicative of inflammation, most commonly infective, but it is more helpful in case of adults. Why? ASO is not very helpful in adults because by the time a child grows up and being an adult, repeated infection already will have a high ASO titer, or some of the adults will not react very well against a streptococcal infection like a child do. Okay, so ASO and CRP are also very highly predictive of neonatal illness. Okay, because in neonates, that is children less than 1 month, many other markers of inflammation are not always present. For them also it is very helpful. Okay, I am just given an overall idea, but you need to read a little bit more. Next is another part is rheumatoid factor. So what is rheumatoid factor? Rheumatoid factor is an autoantibody. It is directed against the Fc fragment of IgG. Okay, that means a particular person starts developing antibody against his or her own antibody. So what will happen? Why this is important? What will happen if you start producing against your own body protein? It is a autoantibody, autoimmune disease. So now what will happen? The IgG will react with the rheumatoid factor. It will form antigen antibody complexes, and these complexes will be deposited in the various body parts. If it is deposited in the big joints, knees, shoulders, the patient will have pain, that is arthritis, pain and inflammation. Because it is of rheumatoid origin, it is said as rheumatoid arthritis. If it is deposited in the skin, it will have erythema marginatum, is rheumatic disease. Okay, there will be skin manifestations if it is deposited in the eyes, uveitis. Okay, so basically any organ can be affected. And the principle is very simple. The patient has antigen his own, the antibody also his own. Now, to detect this, how we detect this? We are detecting the rheumatoid factor, that is the antibody against the Fc factor. So, again, the human IgG is injected into the goat. The antibody that is produced is again mixed with the latex particle, and the test is done. Normally, any value less than 20 international units is not considered to be as raised rheumatoid factor. If it is more, we have to consider rheumatoid as one of the differential diagnoses. Please remember, this is not a diagnostic test. It is one of the test to diagnosis. Okay. When I say this, that means in all other patients who have autoantibodies or in other autoimmune diseases, this rheumatoid factor may come as positive, because this is not a highly specific test. Okay. I think in the PSM you have read about something about sensitivity and specificity. Okay. So these are very sensitive tests, but not very specific. Okay. So these are the common 3 tests were done. In your exams, mostly these 3 will be asked to you. There are basically 5 important questions that you must answer. What is the test? How it is done? What are the normal values? That means if it comes high, and what are the interpretation of this test. And always please read what are the false positive and false negative causes. Okay, understood? From the practical point of view or the exam point of view, this is what is needed. Before ending, one last part is all these tests can be done in a quantitative or qualitative basis. When I say qualitative basis, what do I mean? And when I say quantitative basis, what do I mean? Any idea? Correct. So when I say qualitative test, that means whether the particular antigen or antibody is present or not. Yes or no. That's it. But sometimes we need to know whether it is high, very high, or extremely high. When I try to categorize on the amount, we say it is a quantitative test. Now these are not highly specific tests. So whatever quantitative test that is done is known as semi-quantitative. When I say semi-quantitative, it is an approximate quantification. Not exact, but approximate quantification. Okay. So why it is required? One of the reasons of false negative test is what is known as prozone phenomenon. What is prozone phenomenon? See, for an ideal reaction, you need both A and B in equal amounts. So each and every particle of A will react with particle of B. Now suppose you have 10 particles of A and say 1000 particles of B. What will happen? Only 10 particles of A will bind with 10 particles of B. Rest 990 particles of B will be freely available. You will appreciate the test result as negative, but it is actually not negative. It is actually false negative. So how we can rectify this effect? By diluting the sample. If we dilute the sample 10 times, what will happen? Now after 10 times dilution, it will have 100. Further dilute 10 times. On the second step, what will happen? You will have 10 particles. Now at the second step of dilution, you can see a definite positive reaction. This is why quantification is done. So if in exams you are asked, or even when you will be practicing, you must remember, if you are seeing a patient and clinically the patient looks, or you perceive that this patient is having this disease, and this test most probably should come positive. But if the laboratory reports as negative, you must ask for a quantitative test, because it might be the reason that the antibodies or antigen in either case may be so high, there is a formation of prozone. Okay. So the purpose of dilution is to eliminate prozone phenomenon. Understood? Any further questions? No. Go back and read about these three tests. Read agglutination, precipitation, because whenever you will be saying latex agglutination, the next question would be what is agglutination? And if agglutination is asked, it will be asked about precipitation reaction. These are old tests but still important. Finally, one more test that you have not answered is a Coombs test and reverse Coombs test. Okay, because it is a practical class, I am not delving into it, but go and read Coombs, reverse Coombs, complement fixation, ELISA. These are important. Okay.